So starting. Recording now. So our first presenter will be Miss Aiden, H. Aiden, about the laser. What is laser? Is that correct?
Yes. My name is Aisha Aiden. I'm one of the registrars in this hospital. I would like to talk about shortly. I will try to explain what a laser is. We know that laser produces a very narrow beam of light that is useful in many instruments and many technologies. And the laser, the word itself stands for, it's actually an acronym, light amplification by the stimulated emission of radiation. I will come to that later. It actually explains how laser is produced. So when we try to understand, it's actually easier to compare with the normal light that we see as a sunlight or the light produced by just a simple light bulb. You see on the right side is the light produced by sunlight. We can see there are different colors on the right side, and their peaks are not aligned at all. They are very different. It has different wavelengths. In the end, we perceive a white light combining all these different wavelengths. On the right side, we see the laser energy. See, the wavelengths are similar, almost the same. They align, and they're all the same color. Seeing in a different slide, the same thing. So the light energy produced by the light bulb is directed to different ways. But laser, we direct it to in a very narrow area to a certain spot. It's the same color, and different word is monochromatic. It has single wavelength, and the other one, their peaks and thirds are aligning. So that means it's coherent. So all these features makes laser that's how we can make it narrow. That's why it's so bright, and it can be focused in a very tiny spot. And the reason that it stays focused and because it doesn't spread much, it can travel very long distances and it can be very powerful. That's why we can concentrate a lot of energy on a very small area. And how do we produce this energy? There are three simple steps actually. We need to have an atom, and we need to excite the atom with a source of energy, and there will be a stimulation of the release of photons, and we need to amplify this process. That we need to see a basic. We need to turn back to the basics of physics. So we see an atom model here. We have a core, and then we have the orbits with different energy levels. If we excite an atom, we'll also excite the electron. It will move on to a higher level of energy. That will be an unsteady state. And when we do not do that anymore, the electron will go back to its own original state, which will again be a lower energy level, and it will release an energy that we call a photon. Here it's another slide to explain this. When we're exciting the atom, the electron is moved to another higher energy orbit, and then when it returns, it releases a photon. That's the second phase, stimulated release of photons. Third thing, we just need to basically put two mirrors so that the energy can go back and forth. And that's the very simple diagram of how laser energy is produced actually. So we need to have a laser medium, which is our atom, which is our element. We need to have two mirrors so that the photon is bounced back and forth. We need need to have a pump source, which is the energy that we're giving, which can be electricity, and then we are condensing the energy as a light laser beam. So we are classifying lasers according to the element that we use. This can be gas, this can be liquid, this can be solid, or a semiconductor. Gas, commonly, we also use in our practice carbon dioxide, helium, argon. Liquid can be organic dye laser. Solid is Nd:YAG, and semiconductor is gallium arsenide diode laser. This is the one that we use in everyday life. That's where we use the telecommunication, the barcodes, that they're using the semiconductor. So this is actually a very good picture just to go back to the basics again. We see two mirrors, the laser beam. So this is the gas one, which is carbon dioxide laser. As I said, we use it in our practice a lot, especially head and neck, and also in nuclear surgery. There is also argon and helium. Solid laser media is, you can see an Nd:YAG that's solid. This picture that's mostly used in eye procedures and also in cosmetic medicine. And semiconductor laser media is the most widespread lasers in the world. We use it in almost a lot of technology, telecommunication pointers, barcode readers, and CD and DVD players.
Now the starting is a bit boring, but the physics and the basics is very important to understand what you're going to use and what you're going to do. Mine is the most boring bit because it's more mathematics and physics. I don't know whether you like it or you like the physics or the mathematics or not, but to be honest, I think it's an important to know how the laser works and how to set up the parameters, which one of the laser that you're going to use. So my presentation would be how the tissue reacts to the laser. So what is the best to use for what? This is the question, the first question to answer. The second one is when you set up your parameters, exactly why you're going to pick up this. I know most of the new machines have, like, this is for the hemilaryngectomy, this is for polyp, this is for mass. But sometimes you use it, but you find that it's not really useful, and you need to play around a little bit in the parameters. So afternoon, Steve will show us how to set up the parameters, how to play with it. But there is a scientific base or mathematically based on that. So this is what I'm going to present. So hopefully you can enjoy it, but I'm not quite sure. Everyone said that it's a bit of a boring, but I think it's important to know what is the reaction. And small things, as we said, that the laser is most of it. It's the colored things that we can see it, but not really all of the laser are colored. But like the carbon dioxide, we add the light. So we have to know what is the tissue that we're going to work on, and which is the best laser would work on those tissues. So we have the wavelengths. So as I'm gonna jump on those slides. We have the laser, and the lasers are different depending on the wavelengths. So we have, for example, from a laser that uses in the eye, and then the dye, which is the argon, or the other laser that we use now, the blue and the diode laser, or the green diode laser, or the old diode laser that have been used, which is a solid things, and then the gas bits, which is the carbon dioxide at the end. So different types of laser with the different wavelengths. So difference between the types of laser. So we can see we need the most absorption of the wavelength. So if, for example, the water, you can see this blue things. You can see that the least effective for the vaporization of the water would be at the the 500, and the maximum of it will be at the end. So for example, if we want to coagulate, okay, now I'm going to go for this because we need the evaporate to take the water out. We go to the highest waves, the most highest wave. So as we go back again, sorry, as I said, I'm going to jump between stations. So I don't like to read it, but I like to just to point up. So we can see that those lasers are the highest wavelengths. So if I want to vaporize things, just to cut out, or just apply something to take it out, I'll go for the highest bit. But if I want to coagulate, okay, what's I'm going to go? I will go for this one. So we have the, for example, the dye things, which the colored tissue, which is the melanin. We don't use it much, but it's in the skin, for example. But, and as well, the hemoglobin, whatever, it's the oxyhemoglobin, will be, you can see the peak is here. It's around the 500. So if I want to use something for the dye or for the hemoglobin, just coagulate, I think the best is to go which one, which is the middle here. So it's usually the dye lasers, whatever that you can use. And I know that this is against the companies, but the blue laser and the green laser, there's no much difference. They used to say green is better in the nose because they are more vascular, and the blue is better in the ears. And actually, you can use even the blue laser to do this effect, which is a vaporization. But depend on the power. So this is the next step. We're gonna take from the reaction. We know which is the better, which is best. But if you have one machine, how are you gonna set it? If you have a carbon dioxide and you don't have a dye laser, like a blue or a green laser diode, are you gonna stop doing coagulation? No, you're gonna do coagulation. So how to set the parameters? This will be my next presentation. So we're gonna set up the parameters. So before according to which laser that we're gonna use or what's available as well. So we know that the water like to have the highest wavelengths for the coagulation, and the dye, we use the most of the colored slate. All of this, it's just depend on what is there, just what's happening, but mine is more similar. I'm going to set it to everyone. So setting up parameter is just when you open your machine, and in the machine there is a kind of a board, and the board have a lot of inputs in them. So you need to know what is the inputs that you're gonna see. So you're gonna see the beam diameter, and it's very important. Okay? And the shape as well is important, but the shape depends on the beam diameter. So if you can see, the dot is a small size, and the linear is more larger size. I'll tell you why in a minute. So once we see the equation, we know why we want to know the diameter of your beams. The second bit is the power, which we know what is power. Setting up power in watts, so how much watts we need. Okay? And then the pulse duration, so what is the type of the pulse that we need, and how much repeated is the pulse. So the pulse is the setting up, down of the laser, or it's a continuous. I'm going to tell you about the two of them. And the repetition, that's mean the rest between the two, each pulse there. Okay, so you can set up the timing as well. So the time is a factor, and then the energy density, which is how much energy that you're going to deliver to the tissue. Again, you know, it's a bit of a math and physics, and it's very boring, so please bear with me. Okay. So you will find in the board there, so what is the type of the beam that you're going to do? Okay, so which one you're going to pick up, the shape of it, and the diameter. It's very important. I'll tell you why, and I'm going to repeat this again. The second thing is the power, and how much that you're going to set the power on. and then the pulse duration, so how much that you need the pulse to be, and the repetition of the pulse as well. So how much there will be rest between each of your pulse. And then this is the energy density, which is the how much the energy you're going to do, and depend on this. So the energy, it will be, if it's a low energy, it's a bit different, or the result will be very different from the high energy. And it depends on this. You can get your ablation, things you can ablate or cut or fiberize, or you can coagulate, or to a minimum tissue reaction. So for example, there's something called low level laser therapy that we use it before in the skin. So before in the skin, they use, for example, the vitiligo skin condition. They set up the, the ultraviolet lights. Okay, the laser is not different from the ultraviolet light or any light. It's just a condensed light. Okay, so a condensed light can have every light have an energy. Okay, so it's different. So the best thing in the ultraviolet light is a low level energy. So the lower the energy is, the lower will be the effect, and it will react on, I will do something in the tissue there. You're gonna set up, as I said, you'll find your machine like this, and there are a lot of parameters there. We're going to talk about those parameters later in practice. So we said before, the beam diameter is different, and it's very important to see how much is the diameter. So the smaller will make a much or different effect from the larger. And I'll tell you in a minute. I'm going to show you. So this equation is very important, okay? And this is the best that I need to speak about. We have the energy, so the effect that we need to do. It's the time of the laser. So how much the laser is going to be set on, okay? So how much they may be on and off. And it's different for also the factor is not here in this equation. Is it continuous? That means there is no repetition, or there is a little bit of a repetition. So the time is almost not only the time of the laser, the time of the laser that's set on, and the time of the laser being pushed or pulsed in. The device have two parameters for this, which is the repetition. Okay, how much is you want? Is it repeated or continuous? And the second one is the time that you need to set the laser on. Okay, and this is directly proportional with your energy. So more time, more energy you're gonna deliver. Okay. So what else? The power. So it's also the power is directly proportional with the energy. So the more you put in once, the more you get as an effect. The last bit is there. It's called the surface area, which is the beam that I've mentioned before. So the beam is indirectly proportional to the energy. So the larger the area you're going to use, so for example, if you use a dot, that means you're going to deliver much energy. You're going to do it as a linear or semi-lunar or whatever, which is larger in diameter. That's mean your energy will be lower because it's indirect proportion. I know, sorry for this. It's a boring things and it's more scientific. Yes, but I think it's important when you put up your machine. So again, so the direct proportion is the time. So if you put more time in, okay, you get more energy. If you put more power in, you get more energy. If you put more or larger surface area, you will get less energy. So again, so this is it, and I'll show you. More video. I will show you that one first. So what I'm doing here is a small ventricular cyst. Okay, so I'll show you the difference in the laser aiming beam. So when you change the aiming beam, it's the same that you're gonna do. So this is a small spot, but not focused. So you set your laser and you focus on the spot that you want. This is a small dot. Just this again. Okay. So I need this bit. Okay. So you can see here, this is a small dot. I'm gonna focus it. So the smaller the dots will be the more the power. So that if I need to cut it, but I started with the small dots, but I ended to the large one because I thought that's the energy there is more there from what I need. So I make it more linear. But you can see that the device can change the shape, and when you change the shape, you change the diameter. So this one, you can see, this is more likely to be for a coagulation. If I want to coagulate, I will make the aiming beam more larger and more disturbance, or so the energy will be less because the laser is more likely to be a concentrated aiming powerful tool. So if you make it more disturbed, that means the energy would be less. Despite you put the same watt. So the watt is not the energy. Watt is the power. Okay, you can put the watt on 10 watts, then you get a different effect. Okay, because people think that if you put the watt down, will make it coagulation. If you put it up, this will be more ablation. It's not that only. You can change the aiming beam and change the shape and give you the same effect. Okay. And also, you can see that we can change it to another shape. Yeah. So, and you can also change the length of your aiming beam. So it's not only the shape, it's also you can change the length of it. So on the parameters, we can up in the afternoon on the with the in the theater, you see how to do this as well. And you can see that once you have it, you can use it as a scalpel, depend on what you want. Sometimes you need it more straight, you need it more curved. So the aiming beam is very good in that things. And you can see, just as I found that shorter and more straight and increasing a little bit of a power will give me the effect of the. You can see when I've done this, I find it's more not ablating, it's more like coagulation. So I asked them to increase the size. You can see and I make it more semi-neural and I increase the watts. So playing with these parameters will give you what's the effect that you want. I prefer the low watt and see the coagulation effect. And if you find the coagulation effect is there, that's okay. Increase the watts up. If you find it's just cutting from the start and it's good, that's good for you. Because a lot of time the machine itself is a little bit higher, so set it up higher than what you expected, or sometimes it's lower. Don't depend much on what's in the setting. And if I'm working here and I find the blood vessels, what I'm going to ask them either to increase the size of my aiming beam and decrease the watt a little bit, so I coagulate and then put the watt up and increase the size of the aiming beam, so I get my ablation. Okay. See, as we have mentioned before, see in the equation that I've shown you, let us complete the video. I'll tell you what I will say. And in this way, in this video, you can see it's a little bit like more like oscillating. So that means that I'm not putting it on a continuous. I'm putting it on a repeat rather than. As I say, when you work, you can change from semi-neural to the straight line, whichever according to what. Okay. And then once you reach what you want, I increase you can see now I put it on a continuous. You cannot see the oscillations of the laser. So this is more to be continuous because I know where am I. I was afraid that there is any vessels or anything on the set. So you can just Okay, back again to the presentation, and I'll tell you something in a minute. Okay. As we said before, besides the power, the pulse. So this is, as I said before, so the longer and continuous the pulse, we get the photochemical or the photothermal effect. Is the cutting or fiberizing. So the shorter the wave and make it interrupted, make it more likely to be the not the thermal effect, the ablation or the plasma ablation, which is the photosensitization. This is for the time. So we set up the time according to what we think that this is the most appropriate. Devices have the average time that and the repetition is a part of the time, so either continuous or pulsing. Pulse is that mean the laser goes up, down, and there's an inertia between them. So there is a losing of power. When you set it on 10, it will reach 10 in yeah, I know it's in a fraction of seconds, but still there is a bit of a time to set up to the level that you want. But in the continuous, it just if you put 10 watts, that means the laser be 10 watts continuously. Okay, but there's no inertia to put up and down, put up and down, and depending on what is the tissue that you're working on. This is the end of our equation, which is the density of the energy that we need is dependent on that before, which is the time, the power, which is directly indirectly proportion with the subset, and the energy is 5 Joule. Any questions? But I'm going to show you a video, and then if anyone wants the questions, I'm happy to answer the questions. Sorry. So this is the blue laser, and as I said before, the blue laser is in the middle, and it's mainly the most absorption of it will be for it's the best for coagulation, or even you can see that the thermal effect is very, very nice, and it's very, very concise to the blood vessels. You can see this patient have it wasn't a precancer. The patient had in the front is a small leukoplakia. You can see the abdominalization or a lot of new vascularization there. So we thought that's a necessity. That we're going to take it out first and then just see what is it. But we have done like an anterior productomy, a little bit of a biopsy, so it's mainly, and it comes back as a little bit. But this blood vessels should be ablated or just increase in size, so the weight on the vocal cord will be less, so the patient will have a better. You can see the most amazing effect of the blue laser without cutting or burning of the tissue. So this is like a full desensitization. Have a look. It is. It shrinks and almost disappears. Just it will take a little bit of a time for this just to get this result, but it's very nice as well. Thank you for listening, and I'm happy to answer any question. Hope you enjoy this math and physics. Yes, sure. Yeah.
Thank you. That was really well explained. I've got two small questions. One, you showed like a circular aiming beam.
Yes.
Does that get the whole area within the circle.
No,
It gets the edges.
the edges. It's just the shape. It's like
Yeah.
rather than it's a line
Yeah.
or semi-lunar,
Yeah.
become more circular, but not really the area. But it's, you can see the length of it. It's
Yeah.
more like two of these
Yeah.
straight lines rather than one straight line. It becomes two, and you can increase it out as much.
What do you
But
use
it's
that
just
for?
more, maybe coagulation, so just coagulation. But for sure, the area in between
Yeah.
have a thermal effect.
Okay.
So for sure that it will make a bit of a thermal effect,
Right.
but very low thermal effect. That's why I'm saying it. It's more mainly for coagulation. If you put it a small dot, even with the low watt, sometimes it costs the vessel more
Right.
than just doing a little bit of the coagulation effect.
And the other question was, with the blue laser you just showed, what's the sort of largest size of vessel you can target with that? Obviously, those are very small ones on the surface. Just wondering, does it have applications, I don't know, in the node, or what's the largest thing you can kind of calculate?
The largest fibre size is 550 microns.
It's not about this largest size. It's about blood vessels
Yeah.
that have the effect. To be honest, this had somebody had to do like a trial for it. I don't have any experience of coagulation or not coagulation on the thermal effect in the nose. I was to be honest, it wasn't in my mind. Why not to do it? The nose, especially if you have hypertrophic turbulence and you don't want to do the thermal effect on the mucosa. You need just to target the blood vessels, and it's really vascular.
Yeah.
You can do
Yeah,
it.
so you can treat HHT with green or blue laser. That sometimes the vessel you can see.
But it's coagulation effect more likely than the photo. He's talking about the photosensitization and the activation.
You've got in the way that the slide said, you've got the balancing act between the beam diameter and the energy density. So sometimes a smaller diameter beam might be good for a bigger vessel because you can have more energy. The energy density will be relatively higher.
Yeah.
So sometimes it's a case, especially with the vascular stuff, because you can see the effect immediately, it shrinks or it goes. You can, it's a bit of trial and error between diameter, size, energy, because you're looking for a visual clue to see it. I think that's what he was referring to about the. Sometimes you've got to play around with the parameters to actually see literally what works.
Yeah.
Good morning, everyone. I'm Mr. Ayouni, one of the specialists from Hostel. Happy to present one of the presentations of today's course, which is how to use it safely. Outlines in this session, I'm trying to go very concise, as this will explore how the measures which make using laser safe for all people. This procedure, patients, assistants, surgeons, everyone. There's 4 principles of using laser. By using laser, take in consideration patient, users, assistants, and visitors. To proceed with this, we need some points of fix in our mind. This should be aware, as any main surgery, any surgery, put in consideration some points and a plan for his surgery. During using the laser surgeries, we need to hold up another plan for safety. This should be, we should be aware of this and control this. It should be applied properly. This is checklist. First one, how to make the patient safe by covering head and eyes as well, using the proper tools by anesthesia, like tubes, which is matching with the laser and protect against the laser, saline filled balloon, also saturation of gush of oxygen shouldn't exceed than 35%. We have to make sure, meanwhile, I'm proceeding or waiting, that all people using glasses, spare Mr. Ibrahim that my glasses enough. Yes. So Also, the safety should include the people outside, so the label should be inserted later to make everyone aware if you're going around. Surgical safety principles is in terms of the safety while proceeding for the prevention, we are surgical point of view, some sort of thing is that make the procedure going straight away, the targeted plan by using platform suction device to suction the smoke all the time to avoid any hazards from smoke from other surrounding tissue which is not targeted during the procedure. Protect the surrounding tissue by adjusting the laser itself by avoiding defocusing, which may hurt other tissue around. Also, keep cleaning of any conscious debris which is accumulated surrounding the tissue management. The last thing where I'd like to talk about, what if the problem happens? One of the most important things we have to put in our mind, how to treat, how to deal in the stepwise. If there is fire happen or broken, this have to stop gas as a first place, then immediate removal into that tube, make all oxygen saturation to the patient, and trial of intubation if applicable, and this will be considered by the anesthetist at this stage. Then we have to evaluate the danger, evaluate damage that happened, either by bronchoscopy for distal bronchotracheal or by flexible bronchoscopy. This is very important in the management plan and how we deal with the situation later on, and handing over to the ICU people how the damage happens. So this is in terms of the safety, including the members doing the surgery, surrounding the surgery, patient himself, and everything. Thank you. Thank you, Boss.
Would you consider controlled irrigation and suction if you have a fire down the tube? That's, I mean, we do use that sometimes foreign bodies and washing the tracheal tube, trees and bronchi.
Yeah, this is part of options we can do, but generally, this shouldn't become the first thing. We need to stop the source of the fire, because gas is a main source of keeping the fire on.
Yeah.
So stopping it, move the tube, because inflame or arrest the inflamed tissue or the inflamed tube, make it danger or damage to other tissues. As we can move on, we need the third step. Another question?
So we'll continue now on for the application and use for the laser. I'm Dr. Suleiman, ENT degree. So I would like to thank you for your attending our course. Also, I would like to thank Mr. Benamir, our academic lead, and Mr. Ibrahim for this organization for this event. So we discussed before the principle of laser, the benefit of laser. So now how can you use the laser in surgical field? So can we divide it for airway using and non-airway. So I now will give some example using the laser in non-airway procedure. So there is 5 parameters should be considered during using the laser, as we discussed before: the wavelength, power, spot size, exposure time, the cooling. All this were discussed before. So the common laser devices used in non-airway surgery is CO2 laser, Nd:YAG, argon, diode, and KTP laser. So each one have some advantages and disadvantages regarding the using. So CO2 laser, it's the first laser device was used in ENT. We consider CO2 laser as ablative because it's highly absorbed by the water with minimal edema effect
commonly used in Middle East surgery, in laryngotomies or stapes surgery, can be used in oral surgery to treat zinc diverticulum, for example. Also can be used in endonasal surgery and head and neck tumor. Second one, NDIAG. It has a very good thermal coagulation effect, but with greater damage to the surrounding tissue. Consider an NDIAG like coagulation laser can be used for hereditary hemorrhagic telangiectasia to control the bleeding, can be used for terminoplasty, also airway surgery, and using as photocoagulation for the vascular lesion and malformation. Argon laser is highly absorbed by the hemoglobin, mainly used in ophthalmology procedure. Also can be used due to the photocoagulation effect on hemangioma and telangiectasis as well. Diode lasers commonly used in DCR because of for coagulation effect when doing the intranasal flap. KTP, it's strongly absorbed by hemoglobin when compared by the argon laser. So this is the comparison between the types of laser. As we can see, CO2 is highly absorbed by the tissue with cutting and ablation effect. However, NDI is a highly coagulation effect with tissue penetration. Why we consider laser is very good in auto surgery, because to minimize the mechanical trauma, which give better hearing effect during, especially when doing stapedial surgery, with minimal or reduce the post-surgery vertigo or dizziness. Also can be used in the laser for mobilization, the small amount of vascular tissue in the middle ear, like granulation tissue or glomus. This is a short movie using the CO2 laser doing the laryngotomy. As we can see here, the shape of the spot is circle. So when one shot, and we can see the effect of the laser doing very concise laryngotomy. Here, using that diode laser in stapedial surgery, first use the laser to cut the stapedial tendon, then the posterior crura of the stapes. And then removing the suprastructure of the stapes. He can use, as we saw here, can use the laser for vaporization, the small vessels, as we saw before in the previous movie with Mr. Ibrahim, same doing the vocal cord. Now removing the suprastructure of the stapes, then to perforate the foot blade at the last stage of stapedial surgery.
The green laser is similar to the blue laser, so there's not much difference between the two of them in the ears. And so you can use the photosensitization effect in vaporizing the blood vessels or coagulation of the blood vessels as well, the blue or the
green. So this is a picture when just preparing the side and size of the laryngotomy, and this is after the procedure. You see very concise and nice laryngotomy. In rhinology, usually the rhinologists prefer KTP more than CO2 because it's easy to transmit through the fiber, highly absorbed by the hemoglobin, which giving coagulation effect and clearer surgical field. If we compare with CO2, CO2 has poor coagulation effect and hemostasis, which increase the synechiae post-surgery. What the indication? There is multiple indication to use the laser in rhinology. For terminoplasty, release synechiae, DCR, rhinophyma, also telangiectasis to control the
severity, severe epistaxis. As you can see, you can use the Nd:YAG laser treating telangiectasis just to control the bleeder point in hereditary hemorrhagic telangiectasis. So last systemic review regarding using the laser to control the severity of epistaxis in patients with hereditary hemorrhagic telangiectasis, they found argon and Nd:YAG laser. They give good improvement regarding the epistaxis. However, in severe cases, they found in this review that Nd:YAG had greater improvement to control the epistaxis in these critical cases. Now, this is a short movie using CO2 laser treating the rhinophyma, just to ablate the skin lesion of the rhinophyma by CO2 laser. Larynx and airway will be discussed in next lecture. So in oral cavity and oropharyngeal surgery, they prefer to use diode and CO2 laser because the ablation effect and cutting on the soft tissue commonly used in sleep apnea procedure or glossectomy. And this is short movie or the uvulopalatoplasty using the diode laser, just to make vaporization on the mucosa and the muscle of the uvula and the soft and the edge of the soft palate for patient complaining of habitual snoring. Easy, quick, and concise. Bloodless field. Just insert for the below the mucosa to the muscle. So it's very useful to use laser, but there is some limitation. All of us know this. It needs a very good learning curve to deal with this very advanced technology. Also, the time to set up the machine and also for make all the safety measures in place before going on. It's highly cost is high regarding for the device and the maintenance. Also, high level of hazard regarding the patient, staff, and visitor. All this should be considered for using the laser. Thank you. Any questions?
Actually, so just again for having type of laser, okay, it's very important, okay, but you can use a single laser, for example, type of laser like carbon dioxide, do all of your effects. As I said, playing in the parameters, knowing the physics and the mathematics behind, and you can use it. It doesn't mean that's for example, diode laser. We don't use the diode laser much, but because the blue and the green is that diode based as well. So it's more the difference between the diode and the blue and the green laser. It's again physics. Sorry for this, but it's the difference between the normal light and the LED. So the difference is that the LED is an energy to light, no conversion. So it's just like electricity to light. So the same thing. The blue and the green laser is energy to light. So it's an electricity to light laser. The other one has to be converted to light, and then the light comes in it, and then go to be like a beam or whatever. So this is the difference, but they are diode based. Okay? So they are not different, but it's just the new technology. KTB is, as I shown before, we are waiting to Mr. Sahota. He should be here in 5 to 10 minutes, but I'm gonna go back to that one. So So if we see those are the dye lasers, which is here, this wavelength, which is in the middle. The highest one is the carbon dioxide, but you can see here is the KTB as well. The YAG laser, all of this is the KTB. So the KTB is mainly around the 970. Sometimes it's varies 750. So it depends on the spectrum of it. It's a bit of difference between devices. So, for example, the dental one is less wavelength. The surgical one is a bit higher. If you go for KTB for the skin, you'll find it's lower, like the dentist. I don't know why and how it comes, but there's a different wavelength for the same radioactive material or the substance or the being used in. And even you can see even for example, for the diode laser or the dye lasers, you can find the representative of it in device and device. Again, wavelength is important, but not the most important bit to depend on which type of laser. You can use any of them by knowing what you want to do. Is how to calculate your effect. Sorry for this, but you use the blue laser, use the green laser, use the KTB in the nose. There are a bit of a difference in the wavelength, but I think that they have the more effective of the coagulation and working more vascular, wants the more ablation and cutting both with the carbon dioxide to do the same effect. What you have seen in the, for example, in the staphylectomy, you can use the carbon dioxide. We use the carbon dioxide here. We have the autolaser. We can show you just converting the rather than having an aiming beam and using the microscope, you would have a fiber. So it's transmitted through a fiber. And how to deliver the fiber? There is a small cannula that you can put the fibers into, or the suction, and you have a curved bits. You can have a curved suction. You can put the fibers in with a little bit of push, because not much, because you can block in the fiber, but the fibers are malleable. And the other way as well, which I have used it before, I used to tape the fiber on one of my crocodiles, or even in the larynx, you can use the fiber laser, but I haven't used it here because the fiber laser is fiber. Hopefully we can get a new one, but you can put your fiber on any of the bone forceps, and what you can do, just put it on the open edge, the edge that open with the open net of your crocodile, so you can see where are you putting your stuff, so you can adjust the fiber length shorter or longer according to I think say 2 mils from the shaft is very enough, and you can use it and turn it around right, left, and sometimes very nice to get one curved as well. A small stair strip can fix this on instruments that you want to laser image. So those are the points that I'll just, sorry for this, but just back again to what I would like to summarize is just not a specific type of a laser could be used in a specific type of surgery. You can use any of the laser, but depend on how you're gonna adjust your parameters. Still waiting for Mr. Sahota, and hopefully he'll be here shortly. We can take 5 minutes rest.
A question, please.
Yeah, sure.
For the tympanotomy with the circular shaped beam, are we able to choose the diameter
Yes.
to make it larger?
Yeah, the same that was the question that been asked before. It's about this circle thing. It's a two linear effect, and they to become semi-lunar, and they can be longer or shorter. It's not a big issue, and I think that the circle is not the best. You can use the straight, but using it laser for myelotony is just kind of.
So do we need to put the grommet or just the laser?
Sorry?
Do we need to put the grommet?
Yeah, if you want to do put the grommets, but it's just for maringotomy. This is for maringotomy. But I think that the most useful effect is that when you use the laser after having a cholesteatoma, a lot of time that you find yourself that there is a lot of like irregularity of your bone, you can use the the diamond there to make it more smooth. But a lot of time it's not that easy because you can see the sinus angle is a bit going down and deep, and you're afraid from having a bulgy sigmoid sinus. So the best is just to use the laser and apply this tissue, and it give you a very nice effect. I have a video for this, but it's very, very old, unfortunately, and I has been recorded by my old mobile. So I don't think it's nice to present it, but you can see it's amazing to apply everything, and it gets a very good effect, especially for the laser again for the ears. I've used the green laser for the ears, and it's amazing. It's very nice, very concise. It's like the blue laser, and you can ablate the tissue, especially if you have a full plate. So unfortunately, because the auto laser wasn't here because there was a shortage of supply chain after the Ukrainian war. So what's happened? We didn't use it, but I've used it before. The green laser, and on the full plate, and amazing. You can ablate the tissue rather than taking the full plate. So I have 2 cases that I have it on the YouTube as well. So you can see that I've removed the full plate and take the tissue out and put the full plate again. So this is a mobile full plate, and put a graft on it. Hopefully that if we're gonna do reconstruction or repairing, this graft will be more fibrous and you can put any of your procedures on. But if you're using the laser, it's amazing. You can ablate and it's very concise away from the fissure nerve, especially if you have a tissue. Another case as well, I have the glucisome is going over the fissure nerve and going a bit deep. And the problem is that if you dissected it and you want to cut it, it's really, really stressful. But if you have the laser just from away and very, very small, low watts, and even like coagulate, and you find that the tissue will be very weak and it will come out from the fissure nerve rather than putting all this effect. But despite, I think that people think that the cutting is more safer than the laser because the laser can get in the fissure nerve. But I think that no, the cutting is very difficult because mostly I use endoscopy, so I use one hand, so very, very difficult to pull and cut rather than having the scope in one hand and just cut it down with the laser. So it depends on what you're doing. So the laser is not the main instrument that you use in ear or nose, but it's very useful, and exactly what you want for is a specific steps that make your life easy. But without the laser, you can still do good stuff as well. Thanks. So we have like 5 minutes for rest, and again, I'm very sorry I didn't give you they told me I have to give you this instruction about the safety. So the exit, the main exit in case of fire, we have this one, but I don't think it's open. So they said that just go around. There is a toilet, and then just behind the toilet there is an exit door for in case of fire.
Yeah, just want to ask, when you say we can play with the parameters, is there a sort of guidelines or references for some default parameter numbers as a starting point?
Yes. So each of the devices that have this, so you find that we have the Lumen, which is from Boston Scientific, but Calton is the one that who are the UK, and they have their own specific parameters for specific cases. So if you go there, you find in the device there is like an otology, head and neck, rhinology. And you go for the otology, for example, they will tell you polycythoma stabilis, and even this for the stabilis, there is an otolase setting is different from the microscopic settings, because the point that we didn't discuss as well for the fibrolase and the otolase, which is the transmission of the energy through a fiber optic, it's more likely to be higher energy than the microscope, which is the result of a loss of energy through the air. But it's very, very minimum. But I think it's effective. They say there isn't much because it's very fast and it delivers in seconds. Theoretically, it shouldn't be an effect or difference between the two of them. But I find it's there is a difference between using the fiber optic laser and using the microscope or the air transmitting. But the parameters are usually set it up and you can pick up. Most of the time they're a bit higher. And you find the different surgeons have their different setting and their preference. So if you are trainee, I would say just stick to what's your consultant doing and don't depend on what's on the device. They are more experts and they know how to manage with it. Any other questions?
Yes. Also list of non-airway procedures that you can use different type of lasers.
Yep.
In your own practice in this hospital,
Yep.
which procedures you use it on?
Pathology. Yeah, unfortunately, we as I said, it's just we are lucky that we have the autolaser scheme. It was like after they said the Ukrainian war, it was shortage of supply chain, and they are a bit tricky because they put an expired date on the fiber laser and the autolaser, and if you put it in the device, you know where. So it's a bit of a tricky. I don't know how they do it, but it's still valuable and it's still working. You haven't used much of it because each time they use the fiber optic laser, you need to trim it because you can't use it for another patient. So it's like you cut the bit that you have used, but you still have a kind of a long length for the fiber. So after you cut it, it should work for around 25 cases to 50 cases. But we haven't used all of it. But unfortunately, it was expired. We didn't use it for almost a year. Yes, the ears are the main thing. Nose. I think that we should. Sorry, I just need to get the low was. Low was low. No. Is it the main theatre or the theatre lecture?
Yes.
Which one? Sorry. Yeah, we are in the main lecture theatre, so the auditorium in the postgraduate.
You used to say otherwise, Liam.
It's
very nice.
You couldn't.
Yeah.
Sorry again. So Mrs. Salty is here, but just give us 2 minutes. Yeah, he's in the near
Nottingham, an associate lecturer at the University of Derby, and I'm a tutor at the University of Leicester. Just because I'm not busy enough, I'm the NIHR lead for head and neck cancer for the entire East Midlands. We're going to talk about laser in the airway. There are lots of different things that we're going to kind of run through. There's lots of things that have been already covered in talks about why you use certain types of lasers, which bands are better, and realistically, what we're going to primarily talk about is the assessment of laser in the airway. So, everybody knows what laser is. I'm sure you've already been hit with the laser acronym of it standing for light amplification by stimulated emission of radiation. Laser, if you've watched enough Austin Powers as a whole. It is simply a tool in your armamentarium of a choice of device that you use to administer something to end with an outcome. Yeah. So whether it's a knife, a fork, a spoon, a monopolar, a bipolar, a ligashort, a bizact, a laser, a robot, it is simply a tool. Yeah. The primary thing about lasers in the airway is about the assessment of what's appropriate and what is going to give you a lot of mischief, for a better choice of words. Obviously, the way you manage benign things with malignant things is slightly different. We'll talk about classical methods such as the Steiner technique, which is very unusual from a ENT point of view, how you chop things out, because it's very weird to traverse through the middle of a tumor. And the Steiner technique is where it all comes from. There's also the classical method of going around it all. Lasers aren't exactly a new thing. They've been around for donkey's years, and they've been used in lots of therapeutic measures, in particular in bladders for lithotripsy and so on and so on. So there's this great book by Wolfgang Steiner, who was basically the benchmarker of normalizing this, and then, like I say, we'll talk about the Steiner technique. This is the entire talk. We're done. Wonderful. This is a book by Gregory Weinstein, and I want to say it was published around about 2000 when I went to med school. So it's a 23-year-old book, but this basically summarizes all of head and neck cancer in about 3 pages. Yeah, and this book gives you these great summaries of, well, what are the options that you can do in certain types of cancers as a whole. So if you look at the table on the left, which I've coloured in blue, which is the glottic cancers, the other side is looking at the supraglottic cancers. And you look at this and go, oh my God, how am I going to get this? How does this make sense? How do I know on the assessment that if I've got a lesion like this, I could give them an extended vertical partial laryngectomy, or this person's not a candidate for organ preservation surgery, this person's endoscopic, and you look at it and you kind of go, this all seems really, really quite jumbled. What the entire point of this talk is to summarize page 4 and 5 of the Weinstein book to you. This group here, the grey, is a supraglottic tumours. In effect, when you look at tumours, you can either cut them out around the tumour, you can cut out a larger organelle structure, you can open the larynx and access the larynx, or you can take out part of the larynx, or you can take out the whole larynx. Yeah, the whole point about organ preservation is about keeping function while giving appropriate cancer resection and not compromising on both. So the problem with larynx cancers as a topic is it's a whole different myriad of disease. My old boss, Soren Christian, has an absolute great line, and I say this to my registrars, that the punishment should fit the crime. Yeah. So what you treat tumours like this is completely different from what you treat tumours like this. So here you've got a T1B where it's crossing over the midline, and this can probably be treated with transoral microsurgery. It could also be treated with radiotherapy. This, where it's a little bit larger, it'll often do better with radiotherapy. These ones are a lot more difficult and probably not that suitable for organ preservation surgery. This can be treated with a cordectomy, and you'll see this later when I've done one. Here you've got a bit of an issue again, and then obviously sometimes you actually need to just take the entire voice box because organ preservation surgery is not appropriate in some patients. You have to accept that as part of your assessment and your workup, but you need to assess to do what's right for the patient. So when you start working, everybody in your studio, the past, your friends, enemies, the art, all above, your own ideas are all there. But as you continue painting, they start leaving one by one and you're left completely alone. And if you're lucky, you leave, which is often the way I think of organ preservation laryngeal surgery. That these are techniques which started getting embroiled within Europe at different times. So if you go back to the 80s, we went through 2 very different strategies. Mainland Europe, particularly the Spaniards, yeah, and the Italians, they went to open laryngeal organ preservation surgery. In the UK, we went towards laser surgery. Yeah. As things creep, and as things have creeped in regards to oncology, more and more oncologists are happy to treat the earlier cancers. But because you don't get to practice on the earlier things, you then potentially are de-skilling. And one of the things about organ preservation surgery and microsurgery is the fact that actually you need to get the practice to be able to do the more difficult stuff. Because if you don't do the basic stuff, you can't do the difficult stuff. And that's true with any element of surgery. Hence one of the reasons why we're in our unit, I'm very happy that we're a very surgically bent unit in regards to managing these things. So if you look at your assessment of laryngeal cancer, there's a really good paper from about 10 years ago by Carney et al. On the assessment of laryngeal cancer. Obviously, you take your history, you take your general things. Dysphonia, is it persistent? Is it changing in nature? Dysphagia, is the larynx working? Are they getting significant amounts of aspiration? Are they having breathing problems primarily? Ferdotalgia, neck lumps, and so on. If you want to know the occupation, smoking alcohol history. The occupation for laryngeal organ preservation surgery is absolutely fundamental in your assessment and subsequent treatment. You will potentially treat lecturers, yeah, so people who are professional voice users, in a completely different way that you may treat other people. And you need to be very, very aware of this because you might do something that may sabotage somebody financially indefinitely in those types of scenarios. You examine as you do always. In an ideal world, you examine the neck, you examine the oral cavity, you check for laryngeal fixation on the outside. Your fibrotip nasendoscopy wants to look at where the lesion is, what's affected, more importantly, what is not affected, because that does change things. And you want to check your vocal cord mobility. Is there any impaired mobility? Is there fixation of the vocal cord? This is one of the types of cancer where a functional component is written into the T&M stage. A lot of people don't clock that. Yeah, for T2Bs and T3s, the movement of the cord is in the staging. Yeah, so whenever you're assessing somebody, just be really pernickety about making sure you document that A in your head and B on the piece of paper. Yeah. In an ideal world, you want to use stroboscopy to see if there's impairment of the actual vocal cord. How many people use stroboscopy routinely in their practice? It's not commonly used, and it's something that's often missed. So if you have a laryngeal lesion in an ideal world, you want to use stroboscopy to tell you how deep it is as a whole. Yeah, it's one of those things that everybody kind of looks over. I always find it weird because laryngology is always just kind of pushed aside. Not that I'm a laryngologist, but the assessment of vocal cord lesions is often forgotten for the strobe. You want to EUA them and biopsy them to prove it. You want to get an accurate representation of where the tumour is, where it's going to, and where it's not involved as a whole, to then figure out where, if you can do resection, what you damage and affect. Imaging CT is better for laryngeal framework. Some people use dual beam CT nowadays. Some people use MRIs, but I'm a big fan of CT for larynxes. So this is my cheat sheet or my aid memoir sheet that I use for laryngeal cancer. I always have this out available on my phone, even in the MDT. In effect, when you look at this, I will talk about glottic, and then we'll talk about supraglottic and subglottic. Glottic cancers are the most common type of cancers, then supraglottic are next, and the subglottic make up a tiny percentage of 0.5 to 1% of glottic cancers. This is the rarity, or the hen's teeth, or the zebra hoofs, whichever way you want to put it, of glottis. So when you look at the glottis itself, your T1A means the tumour's on one side of the cord, and it's only on one side. The anterior commissure is not involved. T1B is crossed over, but the mobility of both cords has to be normal. The second there is upstaging from mobility issues, you go straight to T2. Sometimes they're subdivided into T2A and T2B. The way I think about it is the larynx has got three bits. It's got the level of the glottis, the level of the supraglottis, and it's got the level of subglottis. So when you've gone from one side to the next, that upstages you. Yeah. So if you've got involvement of the cord going into the ventricle, into the supraglottis, that upstages your T2. Yeah. However, if you've got a lesion that looks like a T1, but the cord isn't moving, i.e. the tumour's got bigger and invaded the cord and stopped its mobility, that'll upstage you as well. If you have fixation of the arytenoid, it could be a tiny little cancer which is like 3 or 4 millimeters in size, but that'll upstage you to a T3. Yeah. The T1A, one side, T1B crosses anterior commissure to the other side. T2's mobility, or another subsite. T3's is fixation, or potentially it can be additional sites of 3 sites sometimes. T4 is where you've got extralaryngeal spread. Sometimes it's split into T4A where you can chop it out basically, and T4B is when you can't chop it out. Yeah. Your supraglottis is very similar to your subglottis, so I'll kind of do them together. These are where one site's involved. 2 is when the second site's involved, or the fixation of the vocal cord. T3 is with laryngeal fixation, or there's local invasion around the tongue base. Because an epiglottic tumour can go into the tongue base. T4, it basically invades through. Again, T4s are respectable. And this is the same for the subglottis as well. Yeah. It's slightly unusual because when you look at oropharynx, it's like 2 to 4 centimeters, up to 0 to 2, 2 to 4, greater than 4. This is bloody massive and it's going to cause you a load of trouble. Is basically the staging. Yeah. Whereas this is subtly different, and it's that nuance on the vocal cord movement and fixation. And that's the thing that people often overlook in their assessment. Yeah. And I know I'm banging on about it, but often you'll have me specifically question you what was happening with the vocal cord. Was it moving? Was it not? Yeah. So, radiotherapy for treatment. Yeah. So a really simplistic way to look at this is your T1s, I've written A there, but your T1s should be suitable for transoral laser microsurgery or radiotherapy. Your T2s could be microsurgery. They may be TORs if it's supraglottic, or they may be radiotherapy. Your T3s, because they're stage 3 disease, they need to be dual modality and therefore chemoradiotherapy. And we'll come back to the controversialness of that in a minute. Your T4s is what we class as a big chop, that you're basically not suitable for organ preservation. Your larynx will need to come out. So when you look at the vocal cord mobility, the other thing you want to think in your head is this person aspirating? Is their larynx actually working? Yeah, because you can have a T2 lesion, but they're aspirating, their larynx isn't working. And actually, they probably need a larger punishment to fix the crime. Yeah. So some places don't offer transoral laser microsurgery. Who works in a unit that offers laser surgery to the larynx? That's probably about a third. Yeah, so 2/3 in the modern world, 2/3 aren't offered it. So, as a consequence of this, because of what we're kind of insinuating here, a lot of the time as ENT surgeons, we just give up the work to the oncologists, which isn't a bad thing if you're happy to do that. If the only tool that you have in your armamentarium is a hammer, everything that you look at looks like a nail. Very occasionally, you'll pick up into your toolbox and pick up a screw. You can still hammer a screw. It's just not designed to do that, if that makes sense. The other thing is there is a fine flaw, and I know surgeons often fight for surgery, and this is one of those talks, unfortunately. You've only got one shot of radiotherapy, yeah? If you've got a T1 lesion, you give them radiotherapy, it doesn't settle, and they get a radio-recurrent cancer. The problem then comes is you're not going to offer them organ preservation surgery. You're going to offer them a laryngectomy straight up. So you have no in between. You kind of go, oh, you can have a bit of radiotherapy, you've got an early cancer, it's back. We're going to chop out your entire voice box. Yeah. There's no second bite or third bite or fourth bite of the cherry. You've literally got one bridge and you've burnt it and it's done. Yeah. So that's my only thing about not offering laser microsurgery. Yeah. Cool. This slide is important. Yeah. So the principles of laryngeal or organ preservation surgery anywhere is you need to chop your cancer out or deal with it locally. You need to make sure your margins are clear, which are always contentious, but the laser and laryngeal stuff is actually quite good. You need to aim that whatever punishment you give them, you need to make sure that you're not giving them multimodality treatment kind of for the sake of it. So it's not, adjuvant treatment. You want to try and give them one treatment that does it all. You want to make sure that you try and keep them away from a tracheostomy tube, i.e. a breathing tube. You want to try and keep them eating so they don't have a feeding tube, and you want to protect the airway so they're not aspirating. They are the fundamentals. So the top three are kind of the main oncological things, and the bottom three are the main kind of outcome measures that you want to look at. So the whole point of all of this is to preserve your function without compromising your cure rates. Yeah. So what are the issues with transoral laser microsurgery? Yeah. So you'll see this when we go on to the second bit and we go around into theatre. Now, I know this will have been spoken about in the earlier talks overall. One of the issues is that you need straight line working. Yeah. So your positioning needs to be in the right place. Some people, you just get poor access to the larynx. They can have a small thyromental distance. They could have a receding jaw. They could have big upper teeth. All of the things which makes it quite difficult, primarily, to get access to the larynx to actually access it from an endoscopic point of view. The movements are counterintuitive. Things that go up, go down, and so on and so on. The instruments that you use are very small. You need to have hand-eye alignment. Yeah. The instruments, you need to be really wary of a tremor. So I'm a big advocate of using a chair with arm supports. If you're not that au fait with that, or you haven't got that, you can use a trolley. You put your arms on the trolley. That'll help stop them. Some people, I don't drink tea or coffee, but some people, when they're doing microsurgery, don't have tea or coffee on the day of surgery to try and decrease the risk of tremors, because a small risk in tremor with the micromanipulator can cause you a lot of trouble and a lot of grief. The instruments aren't what's called wristed, so you can't do this. Yeah, so when we do robotic surgery, the thing about robotic surgery is they are wristed, and you see my arc of movement here is about 120 to 140 degrees. But with the robot, the arc of movement is 358 degrees. Yeah, so it's 2 degrees short of a circle. Yeah, but because these aren't wristed, you're kind of moving like this. So when you're doing laryngeal surgery, you're on a pivot point like this, like you're doing laparoscopic surgery with robotics. You want to keep your arms in, and you want your robot to do the wristing out the angle. So the actual methodology is completely different. You've often got to kind of vision. It's slightly different when you've got the microscope there. You have to work on these what are called straight line optics. You need to look at the alignment of the CO2 beam, and I can honestly tell you it's an absolute pain in the arse when the CO2 beam is not working properly. Very technical term. You want to be able to get yourself in the positioning and repositioning. You want to keep that distance about 40 centimeters. So it's a lot further working distance than you'll be used to for otology when you're doing mastoid surgery. And primarily it's because you need to get the instruments in, they need to be fed in, and you need to be able to move them appropriately. So the working distance is quite long. Yeah, and people find that quite hard because your arms are kind of stretching out, you've got a microscope in front of you, and then you're kind of moving things over here. Yeah, so you want all of those things, and there's definitely a learning curve to it all. Anybody recognise this guy? That is Vin Polari on his fellowship. That's when you know you can dig out old pictures. When you get the professor of Marsden on his fellowship and put a picture of him up on your talk. So this is the absolute essence of the Weinstein book, yeah, from the larynx point of view. So we're going to talk about the cricotinoid unit. So for a larynx to function with organ preservation surgery, as an absolute minimum, you have to have one cricoarytenoid joint unit working. What's a cricoarytenoid unit? That's one arytenoid cartilage, the cricoid cartilage itself, the cricoarytenoid musculature which moves that side, and a functioning set of nerves in both the recurrent and the superior laryngeal nerve to move that across. So you can take one side out, you certainly can't get away with taking both. Because the second you take away both, you lose laryngeal function, and the larynx is actually useless at that point in time. You get problems with airway, more problems with breathing, and you've got problems with their voice as a whole. So the cricoarytenoid unit is the absolute essence of laryngeal preservation surgery. So this is what it comes down to. It's an arytenoid, cricoid itself, and the muscles and the nerves that supply it. My registrar who's in the room with me biopsied somebody a couple of weeks ago with a tumour right over the cricoarytenoid joint and came back as an SCC. And we'll talk about him shortly, about the difficulties in that scenario, because he is going to get problems if you're from laser microsurgery. And we'll talk about it in a second. So what are your diagnostic considerations? So does everybody understand what dysplasia actually means and what it actually is? So you've got normal tissue, you've got florid cancer, yeah? You need 3 cellular things to have florid cancer, don't you? Yeah? So you need to have hyperchromatism when you're looking at the cellular front. So you have to have an increased cellular division of nucleocytoplasmic ratio. When you look under a microscope, it has to get darker. The cells have to want to turn over. Those two are the features of basic cancer production. The third feature is cancers want to kind of invade out of the tissue, yeah? There has to be a spectrum from normal cells to end up to a cancer. So there has to be some sort of transitional way. It doesn't suddenly go like that and flick to a light switch and become that. It has to change to get there, because those steps will have to happen, you know, concurrently or sequentially, but you'll have to have cells that overgrow. You'll have to have the chromatin get darker. You'll have to get the nuclear diving, and then you're going to have to get the outside of them to start invading. Some might happen in one order or another, but all 3 of them give you the features of cancer, yeah? So you get this subgroup of things of dysplasia and cellular atypia. So cellular atypia just simply means cells ain't quite right, but they ain't cancer, but they might not become anything, but they might become something, yeah? And everybody's aware of leukoplakia and erythroplakia. Erythroplakia being the dodgier of the 2. Leukoplakia, the chance of it becoming cancer is about 3%. Erythroplakia, the chance of it becoming cancer is about 6 to 7%. So erythroplakia is definitely dodgy. So red patches on cords, a lot dodgier than white patches. And I know we discussed this yesterday with my trainees in the room of exactly this topic. So when you're looking at dysplasia, what you're looking at is the cells change. So pathologists often have a bit of a wishy-washy way of doing this. But the way you kind of think about it is you're looking at the basal third of the actual epithelium. Mild dysplasia is limited up to 1/3 of the epithelium. Moderate goes up to 2/3. Severe goes greater than 2/3. However, it's not invaded through the basement membrane. Yeah. Once it's invading the basement membrane, that's when it becomes SCC, or cancer as a whole. Yeah. So what is the kind of difference between severe dysplasia and CIS? A lot of people use this interchangeably, but it's where you're starting to basically get invasion not happening, but you're getting this rapid turnover of 2/3. So severe dysplasia and CIS are often used interchangeably. And depending on how your pathologist interprets them, sometimes they'll call them severe dysplasia, sometimes they'll call it carcinoma in situ, yeah? Cool. So these are kind of the big things, and I keep mentioning Steiner, and Steiner comes up lots in this talk. So when you biopsy cancers in the larynx, you can actually biopsy them and then come back and resect them. When you resect them, 30% of the time, you'll have taken out the entire cancer in the biopsy. Yeah, and this is shown again and again with this, but a biopsy isn't a definitive cancer treatment. So if you've got a T1A lesion in your biopsy, you'll often just take it off. I do have the propensity that if I've got a large T1 lesion, I'll do lots of biopsies, but I'll leave a stump of tissue on there on purpose so that when I go to actually resect it, I know where to resect from. But this shows you, in several different series that this is fairly normal and standard. Yeah. So one of the big things of Dejo Eliele's top is he's big about margins, and he's a consultant in Leicester. So organ preservation surgery, like I was saying earlier, in the larynx doesn't follow the normal conventions of everywhere else. So in most places you use a 1 centimetre margin. Occasionally some people use 5mm margin. In the larynx, realistically, you haven't got a centimetre to take. And this often ends up as a millimetre or 2. Yeah. And one of my old bosses uses the term, surgeons are forever judged by their margins, and oncologists aren't judged by their radiation fields and the subsequent problems that you get from that. But your margins are important, but you can't get 1 centimetre in most places because you can't chop out cricoid as a whole. So when I was talking about the occupation of the people, this should link in with it as a whole. So when you're seeing people and you're assessing them, you need to think about, what does the patient want? What's their preference? How important is their voice to them? How fit are they? Your choice of poison, in effect, would be radiotherapy or organ preservation surgery. Radiotherapy, they need to go every single day, Monday to Friday. You just go for an hour slot for 6 weeks. Organ preservation surgery, you can go to theatre, have your resection done. You may need a second look at 6 weeks. Yeah, but it's a one-stop sitting with a quick general anaesthetic in the grand scheme of things. Yeah? Even a difficult resection of a hemilaryngectomy is done in under 2 hours. So it's not that quick, but it's not that long, if that makes sense. Yeah. The big things for me are the occupation of the person, recreationally, professionally, and how they generally use them. Like I say, I often use a lecturer as my main guidance of people that you need to be really careful with their voice, because you can ruin somebody's complete life by messing up their voice. And ideally, you should have stroboscopy. Yeah. Here comes the line of the punishment should fit the crime. You need to have a buy-in that if somebody's going under transoral laser microsurgery, that if it fails, yes, you may have the choice of radiotherapy, but if you eventually keep on failing, you may need a laryngectomy. Yeah. Some people do laryngectomies for T3 cancers, and their justification is there's organ dysfunction. I know quite a few surgeons within close enough distance that will upstage T3s to T4s and so on to offer them surgery, which isn't necessarily the best thing to do for patients. So this is my simplified way of thinking, well, how can you chop out a larynx? Yeah. So let's run through this. So you can remove part of the cord. Yeah. And that means a bit of the soft tissue of the cord's involved itself. You could take out part of the larynx plus minus the pharynx. That means the soft tissue is involved. You could vertically cut through the larynx, get into the soft tissue, the inner table of the cartilage, and you can remove that. I give a talk about vertical partial laryngeal surgery, which is rarely done in the UK. There's only about 4 centres in the UK that offer it. But I won't mention that, but if we need to talk about it, I'll get my laptop and show you afterwards. You could horizontally cut through a larynx and get access to it, and you could take out things from the inner table. Once you've gone through both tables, everybody understand this concept of tables in the larynx? Yeah? I will explain it in a second. So if we talk about your frontal sinus, yeah, your frontal sinus is an outer table, which is the outside of your calvarium. Yeah, so it's i.e. the outside of your skull. The air in the middle is of the frontal sinus. The inner table is the bit which is protecting the inside of your cranium to your brain. Yeah, So the outer table is that bit, the inner table is that bit. So in the larynx, your thyroid cartilage, you've got a lamina, yeah, you've got perichondrium on each side. The outer table is the table basically going from the outside into the soft tissue like the strap. The inner table is going from the larynx, the paraglottic space, to the cartilage. So inner table erosion is there, outer table erosion is here. Does that make sense? Yeah. So when we show you this horrible picture, you can see this tumor here. And you can see there that it's fragmenting there. So that's clear inner table erosion. So you see over here that it looks nice and smooth. And you notice here, it just looks a bit moth-eaten. Yeah. See that kind of rough entrance? That's inner table invasion. Yeah. And you can see it here more obviously as you're going through it. Yeah. So that was blurbing about that. This yellow line basically means you aren't suitable for organ preservation surgery. So let's apply this to larynxes. What can you do in the larynx? Yeah. So if you've got a cancer of the cord, you could have transoral laser microsurgery for the actual cord itself. You could potentially have an open procedure where you get open access to the larynx, chop it out, close it back up. Yeah. But this is what we basically developed in England. This is kind of what they developed in Europe. Yeah. So it gives you kind of a global overview of your choices. Your partial laryngeal surgery, yeah, with or without pharyngeal resections, can follow the same format. You can either do it endoscopically, whether it's with laser, a robot, or you can do it openly as a whole. Your vertical procedures allow you to cut vertically and take out one side. You can't take out the other side if you do that. Very occasionally, you can do horizontal procedures, which are the ones which are called supracricoids or supraglottis. And that's where you've horizontally cut across the larynx at either the level of the vocal cords and taken everything above, or you've gone at the level of the cricoid and taken everything above. Yeah. But the point is you need to keep a cricoarytenoid joint for it to work. Yeah, in that side. And these could be endoscopic with robot laser, or they could be open. Supracricoids, they do them where you basically bring the cricoid up, you stitch it back up. So you chop out everything above the cricoid, and you stitch them back up. And you can either stitch that to the hyoid bone, or you can stitch the epiglottis. Yeah, so it's what's sometimes called as a CHP or a CHEP. Yeah, like I say, these are very rarely done. You know, I've seen helped with maybe 3 or 4 of these ever. Yeah, vertical partials I've done probably about as many as well. They're not common at all. So what we're going to primarily talk about is cords. So your workup for laser in the airway as a whole is laser safety. So you need to have a locked theatre. The windows need to be covered so none of the laser can get through there. Everybody needs eye protection apart from the person who's actually using the microscope at that time. Some people use a laser tube. These are these dual balloon systems. Some people just put saline in them. Some people put methylene blue in the inside of them. Liverpool and Derby don't use these primarily. We tend to use MLT tubes and we just pad them up. We're we are outliers from the rest of the country for this thing, but it's because we find it gives you more space to the larynx around it to give you more space to kind of resect things. We use a couple of neuropathies, large ones to cushion around the tube. We use a low FiO2, so in case there is an airway fire, that you're going to decrease them, the burn aspect of that. We put big wet packs over the face. We have a water bucket basically ready on the tray. We have the stomach extractor connected, and we have a nurse person who is laser safety activator. And we orally, the surgeon says, laser ready, confirm, laser fire, and then you start firing. So cordectomies. So this is the basis for most of transoral laser microsurgery that we're talking about, and the stuff that we'll be doing around in theatre later on today. So you want this kind of straight line view. You've got it. In the jigs that we've got, you're going to get a larynx which will be open. That should give you very straight line access. We'll confirm the focused diameter, working distance for the actual laser, get you into this alignment, but it has to be this kind of straight line working. Even on this picture, it's not straight. You want to identify your lesion, get good access to it, whatever scope you're using, a Lindholm, whatever. Then you want to have a look at it. Often, when you look at these things, there are different choices of how to do things. So there's these classical ways, and there's the Steiner technique, and I'll run you through them both. Yeah, I'm not great at the Steiner technique. I tend to be a bit more conventional. So there are several things that you can do. So in your assessment, when we spoke about stroboscopy, the other thing you can do in theatre, you can inject with saline or water to see if a lesion's superficial. You can lift it up. And that's often a technique that I use in theatre. I use basically a big sucker, and then I use an esophageal injector. You can buy laryngeal injectors, but they sometimes are quite hard to get hold of. And I inject saline. So I'll often stick a needle in here. Me and my reg will then inject it up. This will lift it up, and it will make it easier to resect it. A, because you get a bit of water under the tissue. B, it shows you it's superficial. And C, it gives you more space to cut because you're making that dead space in between larger. So in a cold steel technique, you'd kind of cut around like this. Now, sometimes in this, what I'll do is I'll put loads of puncture marks like this, kind of dot them up, and then I'll join them. You always want to keep it attached on one side, because if you take it off on all four sides will kind of move like that, and then when you grab it and you pull it, it'll rip. Yeah. But what I tend to do is I start on one side and work down, normally on the lateral aspect most of the time, because most of the things are on top of the cord going medially. So I'll normally make my lateral cuts. I'll then make my top and bottom cuts. Then I will mobilize it so that it rolls like that. Yeah. I'll then assess once we're past it, and then I'll cut on this side, or occasionally I'll flip the entire thing round. I'll cut on the back of it. Yeah. And this is what this is doing in effect. Yeah. And this is this kind of coming out across here. Yeah. And what we tend to do is we tend to use what's called a biomount. So everybody seen biomounts? Cucumber, potato, cucumber. Anybody seen cucumber? Yeah. Anybody not seen cucumbers? Cool. We'll talk about cucumbers in a minute. Have I got? Let me just check. I've got a slide on cucumbers. There, yeah, there's a slide coming on potatoes. Pro potatoes. We like carbs where I work. Yeah. We'll talk about mounting in a minute. Yeah. So this is that. You remember that first picture I said we're going to come back to that larynx. So this is that cancer. This is a full cordectomy that guy's ended up having on that chapter. So this is kind of an old-fashioned technique, so to speak, and I'm calling it old-fashioned, and that's probably a misnomer. This is the Steiner technique. So in the Steiner technique, what you do is you get your tumour. You actually cut straight through the middle of the tumour. This area here, the green area is the tumour. You cut straight through the tumour. Once you cut straight through the tumour, you look for normal tissue. When you see normal tissue, you then stop. You then resect downwards, and then you get a macroscopic margin across it. And then you restart, and then you go across here as a whole. We'll show you a Steiner in a whole. Yeah. So, what do you need for all this to be? You need facilities with laser safety. You need to follow your oncological resection firstly. Aim for a couple of millimetre margin. Preserve function. You must preserve one cricoroutinoid joint. You want to be wary of difficulty of access. We spoke about so thorough mental distance, recessive jaws, big teeth. Steiner methodology if you want. If you go back and you chop this out and you go and your pathologist says, oh, the margin's involved, the good thing is you can go back in 6 weeks and re-resect some more. Yeah? So you get a second bite of the cherry. So if you're not sure, if you go back in 6 weeks and there's nothing there, you don't need to do anything. If you go back and you resect it and there's nothing in the margin, 1/3 of the time there ain't going to be anything in the margin, even without the resection. Yeah. You can repeat it with little ease. You can keep on doing that. And I am aware of people sometimes 3 or 4 times going back to theatre. Yeah. And there's nothing wrong with that. You don't lose your other options. You don't lose radiotherapy as your choice. Yeah. It's a one sitting, one stop shop, 2 days voice rest, and that's it. It really generally has low morbidity. The morbidity starts to come when you're thinking about the arytenoid, which is why I was mentioning that patient with the arytenoid tumour. This guy's got like a small 3-4 millimetre tumour, but his resection is almost certainly going to take out this guy's arytenoid, and it's going to lead to arytenoid joint fixation on one side. So he is at the upper limit of organ preservation, laser surgery, for a very, very, very small cancer. I'll show you some very old videos. I don't get out very much. So this is one of my colleagues, Sean Morton. has the longest laser practice in the entire UK, and Sean's coming up towards retirement age. This is a video from almost 20 years ago. So here you can see this lesion sat in the medial aspect of the right cord, dipping downwards. Sean's assessment here is he's using a 0-degree endoscope and assessing the subglottis, seeing what's involved and what's not involved. It's confirmed that the ventricle's clear. Here he's got his lesion. There's your neuropathies underneath. There's Tracy, who's my boss. She likes to beat me even now as when I'm a consultant. Who's the boss at ENT, not the doctors. Here you can see Sean coming in from the assessment point of view, coming down to where it is. This is a very old laser. Very old. Probably got a stronger laser in your Blu-ray players. Yeah. So here he's got some heart-shaped forceps. He's making his initial cuts through the lesion. Yeah. And you see as he cuts, it gives way. I tend to do these ones, these big cuts laterally, and I tend to then use that to work around. So he's done a classical Steiner technique here, where he's taken out the lesion, gone across it horizontally, gone on the lateral cuts, down, and then he's doing that thing I was saying where he's chasing it up and he's around the corner like that. That's your first bit of the lesion out. The bottom bit's done, top bit's now getting done. Coming across the resection, margin macroscopically is clear. There it is. You've got two bits there. If you're not sure, you take your marginal biopsies. Your marginal biopsies, you can buy them out again. That will help you confirm that there's no cancer around the perimeter. If you're not sure, just take your marginal biopsies. What you want is good micro instruments, yeah, to do this. Decent laser that works with a good focal length. Actually, if you've got suboptimal laser, you want to make sure you don't. That's your marginal biopsy. Lateral bit of the cord. This is his inferior biopsy, and if you look at trials like Pathos, you know this is the type of stuff that Pathos does. That they do oropharyngeal resections, and then you have to take, I think it's 8 biopsies marginally around it, and that's primarily to prove there's no tumour in them. That aspect there as a whole. Done, and this is your superior biopsy at the top. Sean is absolutely meticulous about his organisation in regards to where he gets the biopsies and what they. That's at the old hospital, by the way. In a very nice shiny unit nowadays. You notice there's minimal charring and stuff like that. And what we normally do at the end is we reassess, confirm it looks okay. We get some pictures for photo documentation, prove exactly what you've done, and there you can see a full cordectomy. Got transligamentous, which we'll talk about in a minute. You can see the arytenoid at the back still in there. That'll granulate over. Normally, most people get really good voice outcomes with. Problem comes is when you're starting to go across the anterior commissure. So, the European staging classification for organ preservation and laryngeal surgery, I always find really quite hard to get your head around. The reason is it's kind of 3D structure. So you've got to think about the depth you're in, vertical length, lateral aspect of it as a whole. So it classically goes from type 1 to type 5 cordectomies. What do they mean in kind of simple terms? Yeah. Now, the important things to remember are basically 1 and 3. So if you look at the ligament and the vocal cord itself, the vocal cord will turn and it will have this edge. It looks like a band like that, and it has an edge on each side. Yeah. When you look at that, you break it up to the basement membrane, the epithelium, parenchyma space, your vocal ligament, which is split into your intermediate lamina propria and your deep lamina propria. Then deep to that, that's the muscle. So when we talk about these, your superficial ones are 1s and 2s. 3s are when you're basically going into the cord itself, so the vocal ligament. Then anything kind of more than that is kind of transmuscular. So 1 and 2 are just basically the same thing but different in regards to the depth. Yeah? You're taking off this layer in a 1. In a 2, you're taking off this layer and some of this layer. And here you can see where they go around. So they're the layers you're basically taking out. You're not damaging the actual itself, which is sat underneath it. So once you're going from a sub-epithelium, then you're going into the ligament. Then from the ligament, you're then going into the muscle. Yeah? So a type 3 is transmuscular. This one's up to here. This type 2 is through here. Third one is straight into the muscle. Then 4 and 5 are always so variable in regards to how they actually define them. So a 4 is basically when you're going across the muscle and you're doing a complete removal of that. You often will need to take out the false cord for access because you can't see around corners with a laser. Yeah? So once you're starting to get into the muscle, you need to think about taking off the ventricle. Yeah? So often you'll do that as an access procedure. Once you get there, you want to be going up towards the cartilage. Yeah, that's complete resection. That's a type 4. Yeah. 5s are all kind of split into different ways, and this kind of takes you through them. But basically, these are where you've done extended procedures. So a type 5A is where you've crossed over the anterior bit on the one side. Type 5B is where you've taken the arytenoid on that side. A C is where you take the entire ventricular fold. Yeah? And then a type D is basically where it's extending and you're actually pushing outwards across it as a whole, and then you're going downwards to the subglottis up to a centimetre. Yeah. So subepithelial, you're sticking to the epithelium. Subligamentum, you're going into the ligament. 3, you're going through the muscle. 4 or 5 is anything more destructive than that, basically. Yeah. Because people really struggle with that concept in their heads, so that you've just got to break it down on what you're actually doing. So this is that example that I said. So this is a type 4, this SCC going here, and you can see this kind of almost sub-like extension. This is the cordectomy that we initially did. This is kind of the overall view. I scoped him about 4 days later, I think it was. Yeah, they heal up really, really, really well. So biomounts, what's a biomount? It's a bit of organic tissue. You basically get your mandolin slicer out, put a load of them out, you then embed it in alcohol. So one of the issues is when you chop out the section, yeah, you think of it like a little circle. You then just put that in a pot, you don't know orientation at all. You don't know what's up, down, left, right, and so on and so on. Yeah. Biomount is just a fancy way of saying an orientation slide. You're going to take that out. So what Sean will have done in that video, done that cut, brought it out here, put it on the potato, have super glued it to the potato. And so I often just cut out a V back here so that you know which way around it is, stick it down, then I try and orientate it on each of the bits. The reason is under the process of the path lab, the organic tissue will just dissolve away. So when you orientate this and they make the slices, it'll help them orientate which area there's a problem at. But yeah, that's the biomount. These are lesions at different distances. So this is higher versus lower and so on and so on. Yeah. So you can multi-layer. Oh. So what's suitable for a cordectomy? Yeah. So if you've got a lesion kind of just here on a cord, so you can definitely do that with a laser because that'll be type 1 or type 2. Anything like here, where there's cancer on one side and it's not crossing over to the other side, you could do a laser, you could do an open cordectomy. Yeah. What's suitable for partial surgery as a whole? So if you've got it involving here crossing over, you can do what's called an epiglottic laryngoplasty, or you could do laser microsurgery, but the outcome for voice here won't be as good because you're crossing over to the other cord. Here with an epiglottic lesion, you could take off this with either a laser or a robot or an open epiglottic procedure or a minimally invasive procedure. Here you could do that with a tongue-based resection as a whole. So let's show you some complications. So what type of complications do people get from looking at the larynx? Those two images are the same patient 4 days apart. Yeah. literally 4 days. Yeah. So this was me scoping on Friday, getting an image, and me scoping on the Monday and getting an image. Yeah. So this person had a supraglottic cancer, yeah, involving the arytenoid on that side. Yeah. So you can get granulation. Granulation is fairly normal after laryngeal procedures. You can get edema, then you can get airway compromise, and you can get away with not putting a trachea in somebody than do. This person did need a trachea. You can get laryngeal stenosis, and you can get chondronecrosis. If you expose cartilage, you should give them Cipro to decrease the risk of getting chondronecrosis as a whole. So this is that same person on the Monday after their resection. You can see here what bits we've resected. This is their this is their larynx. So they've got a fixed cricotinoid joint on one side. This side's mobile. You can see it going as you're knocking up and down. This is almost a year later. Stop smoking. See the function. She was swallowing with no problem. She was smoking. She was drinking. Yeah. So what happens generally with the functional results? So transoral laser microsurgery is often better than open surgery. And like I say, if we want to talk about vertical partials, we can do. The outcomes for transoral laser microsurgery and radiotherapy of the patient outcomes is equivocal. So you do just as well in regards to cure rates from surgery or radiotherapy. The thing is, you get multiple bites of the cherry, so to speak. The after effects of surgery really depends on the depth, the extent of it that you had to remove, and have you looked after the CAU on one side or both. And this really dictates where it is. And when you're starting to take out cricotinoid joint units, you need to consider radiotherapy seriously. So there's lots of potential if you're getting problems of restoring things. So things like webs, you can resect them, put what are called shims in. You can divide them, give them mitomycin, and you can re-resect things as a whole. However, I must also mention the robots because I wouldn't be doing my full job if I didn't. As things are kind of progressing as a whole, robots are starting to become more elusive in the general field, but in ENT, they're just becoming more and more predominant as the thing that people talk about. We aren't quite at the stage where the instruments are great from a laryngeal microsurgery, apart from a supraglottic laryngectomy. But at the minute, there's not kind of regular things. You can see me as a learner with a robot. Hopefully, I've not bored you too much. Have you guys got any questions? Go for it.
We talked about the importance of the margins. So is using the biomount is enough, or should we also take biopsies from the bed as well?
It depends. It depends on exactly where the tumour is. If you're not sure and you're starting up a laser service, my opinion there is that you're going to have a pathologist who's not going to be used to the orientation. The oncologist will be going, why are you nicking the work? Yeah. So when you start, you want to do your resection and you want to take your peripheral margins. Yeah. So if you've got a tumour like that, do your resection, do it Steiner or do it other way, get it out, then take your margins. And in that scenario, I'd probably take a deep margin, take an inferior margin, superior margin, I'd take a lateral margin. Then you have proof that those four margins are clear. Yeah. That's how I would kind of orientate it. A lot of the time we don't take those margins. Yeah. As the more and more experience I've got, I actually take less margins now, weirdly enough.
Is frozen section that we do in surgery, or?
I would love frozen section. Yeah. Frozen section is really badly done. Has anybody ever seen frozen section in ENT in the UK at any hospital? Anybody? Parathyroids in Doncaster? It's the only place that I know in the entire country that manages it. Anywhere else?
Parathyroids in Surrey.
In the Surrey.
They also get it in Sheffield, by the way. The endocrine surgeons for that.
Ballard's got too much money. That's what it is. So does anybody, do you know why it's not normal in the UK? Okay. Cool. So what is frozen section? Yeah. So you get your pathology specimen, you fresh fleas it, you chop it up and you look at it. What do they actually tell you in the frozen section report? What do they say?
It's just what kind of tissue it is, but not about the pathology itself.
Correct. Yeah. So yeah. Yeah, but not so in cancers, they just go, this is cancer or not. That's it. Whereas in parathyroids, they go, this is in keeping with parathyroid or not. It literally just says, this is this type of tissue, that's it. So it gives you a very limited. How easy is it to do? Absolute pain in the arse. Not for us as surgeons. It's a pain in the bottom for pathologists because they have to be sat there ready to go to pick up the specimen, to do it quickly, to give you a report. And it's technically very difficult. So it's technically not easy to do. So every time at every hospital I've ever been at, I've never been as lucky, really Surrey or Donny or Sheffield, in regards to this. I've never managed to get the chance to say, can you get frozen section? People are just like, nope. And it's because the pathologists really do not like doing it because it's really bloody hard to interpret. And the thing is the last thing you want to do is do frozen section, get a report, say this isn't cancer, then come back and it is cancer on the formal report, because that does happen. And the same thing happens with parathyroids as well. Yeah, that people go, oh, it's parathyroid tissue, and then on the final report, it's not. So as good as it is, it's a pain in the arse. However, I will throw a little curveball in the mix. Where it's really, 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 really bloody good is in parotid surgery. Yeah. So if you've got a parotid tumor and you take out, knowing that parotid FNAs are really, really bad, 10% of the time your parotid needle test is wrong. The needle test result that you'll get on your cytology is wrong. Yeah. So you have a 10% failure rate of not having the correct diagnosis. So the Americans are really good in the parotids of doing frozen section on table, that they will take out the lump, send it off, they'll get a frozen section with 20 minutes, they'll either give you a total parotid or they won't. Yeah. So that is where it's really good, which we don't offer in the UK. But yeah, frozen section is controversial. I'd love it if you could do it, but they just don't like change, do they? Like anything, yeah. And how do you offer a service that's not offered very often as well? Because there is a technical thing with it. And the pathologist doesn't want to sit there. So, not to get political, why do the Americans offer it? Billing issue, charge, other service. You're getting paid for your time to sit there, and you're getting paid well. But while you're sat there waiting, you can write reports for other stuff, and you get paid for that as well. Yeah. So there's controversy. Mr. Cole, sir.
You're talking about the supracricoid partial laryngectomy.
You don't have my partial.
Preserve 2 CAUs for it to be.
Exactly. I will show you when we're done a video of a supracricoid laryngectomy scope. Yeah. For a supracricoid laryngectomy, you have to leave 1 CAU intact. So it's called a supracricoid laryngectomy, but it's not really a supracricoid laryngectomy because you have to keep 1 CAU intact. I've got a scope of one that James O'Hara did for when I was here. So I think in my first clinic with him when I was his fellow, I've got a video of that, and I'd never seen one before. But it looks almost normal, apart from there's only one cricoretinoid joint in the work. But in that group, in that subset, I know you've heard my organ preservation surgery talk, the big one that I give. When you look at that, you have to have a cancer that's limited onto one side, plus minus going on the other, but you have to have function of that cricoretinoid joint. That person, when you do a supracricoid laryngectomy, is going to aspirate. So if you have an old person who's dodgy with dodgy lungs, do not do that to that person because they will aspirate. They'll either die of the consequence of aspiration, or they'll end up getting converted to laryngectomy. If it's somebody of our age, probably you rather than me, who is physiologically fit, yeah, and you've got a good respiratory reserve, then actually it's not a bad call. But you have to choose your patient, because the last thing you want to do is do that operation, then have to then go back and go, actually, you're just getting a laryngectomy. Whereas they probably shouldn't have got it if they're like an 82-year-old. You know, in a big centre, you probably see one person who is suitable for that probably every 3 years. It's rare as hen's teeth. You just got to be aware of it that it exists. Oh, any more questions?
Couple of questions.
Yeah, go for it.
Yeah, one theoretical, one practically. Theoretically, in case of patient has cancer in anterior cognition, specify this T1A or T1, just T1.
Yeah, it's T1B, we'll say. Just,
T1B.
yeah, well, let's say it's just gone around both.
Yeah. The other one regarding the case, we can do type 1 or type 2. Can we do them? Because obviously most of the cases go for type 4. Yeah. So is it possible to do type 1, type 2, and which cases we can choose for this?
There. Have we ever done a type 1 or type 2 cordectomy for an SCC? How many times have we injected and left the stuff on the leg?
Yeah, we do that very often.
There's my reg. So it's all about the assessment. So when you go down, I wish I'd taken some of the pictures from what I was just saying, but when you go and you assess them, when you EUA them, you do your biopsy. If you're not sure on how mobile it is and if it's fixed to the ligament, if you haven't done steriloscopy, take saline and inject it and lift the cord up. Because that will tell you, can you get away with type 1, type 2. So for superficial SCCs, you can definitely do type 1s and type 2s. You're more likely to be doing type 2. A number of times that we've lifted up the ligament, chopped it out, and it's fine. You ever say, well, you just observe them. So there's a definite role. If you are not sure, trash the ligament. Yeah. Is the honest answer. But I really, really try not to trash the ligament unless I need to. But that should be given away to you in your head when you've done the assessment, because they're probably, if the ligament's involved, probably going to have some impaired vocal cord movement. And if you strobe them, you're not sure, strobe, because your strobe will give away that the ligament's involved or not. Which will then dictate that should you be doing type 3, type 4. So it kind of just dictates what you do as a whole. Yeah. Does that answer both questions?
Yeah.
Now let me deal with the hard one, which is the one I dodged. I could have very easily ignored that question. Because what do you do with the anterior commissure when it's involved? That is genuinely, you think there, and you sit there and you think, discuss with the patient. And I fundamentally, I keep on mentioning it, ask their occupation. I ask about their voice. Because once you've got traversing of the anterior commissure, their voice outcomes are worse than radiotherapy. Yeah. I would be bullshitting to sell surgery to you if I did not accept that. Yeah. Once you've got involvement in the anterior commissure, you're going to get scarring. You're going to get a web. Once you've got a web, you don't have phalangeal movement with tissues there. The back might be fine, the cracorotidial joint, the back might be fine, the front ain't going to be sensation. Yeah. So in that cohort, you can resect them. So you can do laser resections of that, and they do well. But their voice outcome is not as good. If an 18-year-old really don't want to sit there through radiotherapy, chat to somebody once in a while, use a phone once in a while, perfectly fine. Yeah. But don't do that to somebody like a lecturer. Again, I know I keep on mentioning lecture, but people who are fundamentally important use their voice like a huge podcaster. Don't do it to them. Give them radiotherapy. Yeah. That's what I'd recommend. So don't be afraid to give it a go. Sometimes you need to just do it to know what you should and shouldn't do. Not to mutilate people, but sometimes just doing things, you'll figure things out in your own practice. Yeah. Any more questions? Go for it.
Question about aspiration, for example,
Yes.
and cordectomy. Is by the time is it good enough? The other cords compensation, or for example, medialization, variable loss?
Yeah. So most of the time they don't need medialization or laryngoplasty. Neither do they need something else putting in. They normally don't need a shim putting in or anything. Most of the time, the contralateral cracorotidial joint unit will do just suffice. Yeah. So I honestly don't think in well over a decade I've ever seen a medialization as a consequence downstream. Yeah. And sorry. Being a tech hobo. Oh, you could look. I won't stop talking if you ask me to keep on going. You know me.
That's why
You give me all the time in the world.
all the time. This time, last time we tried to. This time to give you.
Look, I'm sure you've kind of figured out I'm not the type of person to belittle questions, because look, we've had these questions. Sometimes you're afraid to ask, to feel like you're not a muppet, just being who's trying to figure out life. Yeah. So if you look at this one, this is least type 4, isn't it? Loads of carbon. These people generally do not aspirate. If they aspirate in the first 2 to 4 weeks. Only by the time that's happened, they often are compensating of their own accord. So with these ones, once you're going transligamental, going into the muscle, I get speech and language therapy to see them, to look at maneuvers to try and open and close the peripheral to help with their swallowing. Yeah. So things like head turn. Yeah. So in this one, because it's a lesion on the left, a head turn to the left opens up the right peripheral fossa. That'll decrease their risk of aspiration. Might need a chin tuck with a head turn, and therefore you get your epiglottis that dips down. So in those two maneuvers, everybody know about chin tucks and head turns. Yeah? If you tuck your chin like that, your epiglottis and your valvular space opens. That gives you more of a natural defense. If you turn your head one side, the opposite side peripheral fossa opens, allows you to swallow easier. So with this one, in the first 2 to 4 weeks, speech and language therapy will probably say they do like a bees. They'll probably just say, actually, if you turn your head, let's try you on swallowing. That often fixes it, and if not, that or a combo of both. Does that make sense? But in the long term, normally they're surprisingly good considering what you've just done to somebody. Any more questions?
Thank you, everyone. We will have a little bit of rest, and then we go to the theatre. I think so. The theatre will be.
Which we've connected up to a couple of components of the operating microscope. And this laser can actually use a fibre as well, so there's a dedicated fibre here. So the laser is for a fibre and a handpiece for difficult to reach anatomy. I don't know if you guys use the fibres here, but you missed it, so that's the way we're to do it. So this is our live port at the moment. We have the arm here, which is a series of mirrors all the way up, which allows the beam to travel right to the end and out, and so we aim the beam exactly where we want it. Okay? Very fragile, because obviously the mirrors, they go out of placement. So these really do need a lot of care. What we have is, so we have the free beam arm here. This is connected to a scanner, which in turn is connected to what we call a micro manipulator. Again, if you're not familiar, so what we have, just if we set up a manual treatment protocol up on here, we would just see a dot, just a red dot, and what we want is a nice focused, crisp dot, so the energy is in the smallest space as possible. So if you look at what we have here, nice crisp dot. The beam's not defocused, it's energy very, very concentrated, and you get a maximum tissue effect. The scanner, what the scanner allows us to do, we can set up a separate protocols on the machine with a scanner in place. So we say ENT, activate 400 millimeters, which means generally we're working at 400 millimeters focal length, which they do for larynxes. And we set the treatment protocol. And what the scanner here, what it allows us to do is do shapes. So Mr. Ibrahim spoke about the circle earlier, which you can see there, and we can manipulate the size of the circle up to 5 millimeters. You can have a line. Again, you can manipulate up to 8 millimeters, and you can have a left or right crescent. Again, I'll just elongate that so you can see actually what it does. When we marry that scanner up to the micro manipulator, what we need to do, so this allows the surgeon to move in any direction the laser beam, okay? This has something called a digital AccuBlade, and what that allows us, or what allows the surgeon to do, if you just manipulate the joystick slightly, the shape. So we're turning it into a smiley face now, and you can go all the way around. If you go to a straight line, you can manipulate that from the vertical.
You can look on the screen. Yeah.
Oh, you can look on the screen as well, yeah.
Just to make life easier.
to the horizontal. Okay, so it allows the surgeon to manipulate the shapes. And with the micro manipulator, when we're setting this up, we need to parafocalize this micro manipulator with the focal lens that we're working at with the microscope. So we spoke about 400 millimeters here, and this just has a couple of rotation rings on here, so we're parafocalising it. So this is at the same, the micromanipulator and the laser is working at the same working distance as the laser, as the microscope. Okay, so that's around 400, and that will give us the crispest beam.
That's a really important point. It's almost a good idea to imagine that you have an old microscope with a fixed lens. So you used to substitute 400mm lens on or a 300mm lens on, and that was your working distance. What happens with a sort of mistake that you can make with these systems is you bring the microscope in arbitrarily to any distance, and you just press focus to find that view. And what can happen is you can be at something like 250, and you can still get down to the larynx, but you end up cramping your work and your instruments. So the focal distance is displayed on the microscope here at 400. And there is also this yellow button here on the Zeiss microscopes will freeze your working distance. Yes. So it's a good idea to set those things to 400 and this to 0 and 400 on this red dot. And then you know where you are. You're then just trying to zoom out and just find where that beam is nicely focused. The other way of doing it is you can have a sort of random focal distance and then you can make some adjustments. I always think the simplest way of doing it is to sort of set a baseline and then bring the microscope in. Because that is the principle at which the laser will cut properly. It is focused to 400. And if the laser isn't cutting properly, it will be a focusing issue. It will be all premised on the distance. So that's really important.
Because you've got multiple variables, and if you change one and then you miss changing the other, then you end up with that problem. And like you say, if you put it fixed, you can't get it wrong, you just put it out until it focuses. Then once you go too far, it will defocus again. Yeah. So then that is the giveaway of fixing it back to where it is. Because you get into the scenario where the laser's set in the wrong place or the microscope, and you end up just kind of cross-covering. Yeah. And then you end up in the wrong place, wrong depth, and so on.
There's another clue, is an audible one. When the laser is focused properly, you will hear a buzzing noise on tissue, and it will just cut clean with no charring. If you're getting charring and more necrosis, and you're not hearing a nice buzzing noise, you should make a micro adjustment, either just by physically moving the microscope in and out, or on the focal group. So you've got a few different clues that you know whether it's optimised or not. You should be able to see those either on tissue or on the piece of wood.
60 knots? Yeah, go for it. So that's because I've got a reflection off something where, and it's fainter because it's a reflection of something else. Yeah.
So if you fire that laser now, does it fire two places?
Two places. But the central will have most power and that peripheral bit will definitely have some power. The other thing is, remember that laser isn't actually the CO2 laser. Remember, that's the marking laser. Yeah. So there might actually be reflections in between. Now literally, all I need to do, and I'm not going to get you to all look back here, is if I move that by probably about 2 millimeters, it's now completely gone. Yeah. So everybody's got their glasses on? Yeah. We've got our laser check, got our wet patches around, do your check. Ready when you're on, Steve?
Okay, super pulse continuous, 2 watts.
Yeah.
Laser's ready.
Lovely. I always just do a smiley face because I don't get out much. So you want a pinpoint. Nice that you've got there. Your laser test. And that's normally your laser test so it's hard. Now I'm going to show you something. And that's this. All I've done here is I just moved the microscope in. Yeah. I've done nothing else. I'm going to move my dot. You should still be able to see it on the screen. Now watch the dot difference. You notice nothing's happening. So I've done nothing. You've just seen it burn the wood. Now nothing's happening. Yeah. Now if I just come out about halfway, same thing. You notice there's really not very much happening. But you notice that if I keep on for ages, you notice you're now getting the same thing. Yeah. But you see the difference in the cut. Before I was pressing it, and I was just moving it as going. I've gone in too close, the laser's not working because it's not focus in the right direction. I've then brought it out halfway between the two, and it's really slow, it's just not cutting. So you do the same thing when you're inside somebody as well. So I know that's 2, 3, 3, 3, 3, 3. Still set up. Now you'll notice now we're back to loose fire. And you notice we're still out, we are still on at the same time of year. That's the difference. So literally, a centimetre will make a world of difference if you put it on stand by stick. Where's the stand by? Get to now everything's safe from that point of view. So that's your test done. We're not going to mess around when you're doing a test straight away. We're going to get straight onto the larynx. So, we've got a sheet larynx. Now, it's always a bit of a juggle of getting the right angle for this. So, we're going to patch you up. Don't be afraid to go first, by the way, please. Because everybody's going to get it go. It's half larynx each, isn't it?
Sorry? Yeah.
So left and right.
Yes, left and right. And
so there's always a bit of a juggle of getting this out.
yeah,
So,
unfortunately. And we don't have a real ventricle here, so we just...
yeah, so the sheep anatomy is slightly different. The epiglottis is almost basically continuous with the thoracarch. So there's that issue firstly. There you are. Now we're in focus. Yeah. Who wants to go first in that? Dun, dun, dun. Yeah,
Do you want some of the instruments to...
Yeah, I'm going to get Simon set up with those in just a second. Simon, why don't you have a look down here, make sure your focal length is set, make sure your interpupillary distance is set correctly for you. I think you 65. Yeah.
Have you touched this much, or should I have done your glove?
I haven't touched it with it. With
But
the
it's just to let you know as well, he can use the gloves, but this is animal tested,
yeah.
so it's approved. None all of the virology is come back as free. That's why we pay money for it. It's
Simon, I'm going to give you some heart shapes to the right.
Yeah.
And I know what you can and can't do anyway. So I'm going to give you just a heart shape, just to get you started. You have the choice of doing a multitude of things. I'm going to keep on you through the main one. Heart shapes to the right, all I'm going to give you is your tool. Is it reflecting?
No, it's in like a black dot.
Yeah, it shouldn't be down there, it's down it's on the camera. Hello, Mr. Sarah. Basically, the beads of cuts to join up the line. And then, with my manipulator, takes up a joystick, right? And it does one that I've got the kid. When you get on it, just try and push up and down, just so you can see how easy it is to move. And obviously, it's going to be variable because some of you might have filled the laser already, and some of you might not. So don't worry about too much. The other thing is just so when you know when you jump on, roughly look at the distance and how far sound is it, because that's roughly where you're going to need to be. Is it 10 minutes each or? We aren't in a rush, so if you want to stand up, thanks, Steve. So yeah, as you pull, you notice the entire larynx moves. So this is why it's a bit difficult with these. So there's not a really good way of fixing these in one place. You can't really stand over your hand on them properly. The other thing that you might not realise is when you're using laser, if you pull the tissue up or down, it changes the depth of the laser. And you'll notice sometimes it's easier to leave the laser where it is and lift up the tissue and push it away. And you'll find sometimes it suddenly just starts to cut. Use it. I mean, you've seen that with me, but sometimes you just leave the laser in the same place and actually just move the tissue to the right place. And it's normally an inwards out, it's not a left block. But if you find the beam, push it in, and it'll sometimes be at the right focal length, and it's just easy to just go and move the tissue. I don't know, that's good. Make your medial cut inferiorly. Yeah. So you call it somewhere. Yeah, probably there. Do that. Start to disassociate it there. So as you notice when Simon, so sometimes you get into the charring, as he's pulling it upwards and out, the pulse of the laser cut is changing. And it's that little subtleness that you need to spot and pick it up. Push it downwards, Simon. Push it into the larynx. You hear that hum? Yeah? He's in the right zone. There. Yeah? So he's pulling it upwards, except not in focus. So you push it down, you get that hum, yeah, of the laser cut. Yeah? So listen for that audible feeling / audible kind of feedback loop as well. So that buzz isn't there. Now push it inwards, deep. About now, it's going to hum somewhere around here.
You should turn up the power.
Yeah, whack power up. Why don't you whack up to 5 so give us a proper power, yeah. So it's got to go on standby, yeah. So anytime you're changing something like the power, it has to go on standby until
So I'll tell you this. Our machine is need a little bit. Oh, I don't know why.
Oh, it's just a bit too
Ready?
Yeah.
Now you notice things automatically change and the cut's going to be deeper now, yeah.
And he's doing it as a small dot, so this is mean the maximum energy has been delivered.
You're concentrating. The other question is, Simon, do you want a line or anything, or are you happy with a dot? You know me, I like a dot. Yeah, exactly. So it's when you think about it, it's stuck down in 3-dimensional on 4 sides, and then the deep side, yeah, in effect. As you make those cuts, it becomes the tissue in effect is easier to pull apart. Yeah. So as you do more and more, you want to do less and less with your hand. You want less traction, which is going to potentially tear it. Yeah? Which is why, like I say, start at one place. And I normally start lateral, get lateral movement, and then roll it all that way. But you can do it anyway as long as you don't follow these things. Start on one side and do the tops and bottoms and work your way around. It's normally like modus operandi. I love the smell that they come in the morning.
I do that to kind of hold it.
Yeah.
Someone looking through the door. Come on, laser's going off. Sorry, there's someone looking through the door without glasses on. Sorry.
Okay.
Turn it off. Sorry, it's all you. They're gone.
Yeah, we'll start soon.
Okay.
It's your boss.
Oh, sorry?
It's your boss just checking why we didn't come to him. So I think so. It's now enough for demonstration. So we're gonna take 5 of you down to the KTB and blue laser. Is that okay? So who would like? Yeah.
We're going to switch and let other people play.
Yeah, because we're not gonna take much time there. So
So do you guys want to go? So do a few.
This one is primarily used for otology, so stapedectomies and mastoidectomies, reduces the reoccurrence of cholesteatoma. And you have a couple of different fibre sizes. Put them here. So this one is called an Ottoprobe. It's where the fibre, which is 200 microns, comes attached with a nice handpiece. So they use this one for otology.
So really nice, comes all in one, and just plugs straight in there. Just pop it in until it's firm, and then the port should light up, and then tells you that just asks you if you've got an eye safety filter connected. An eye safety filter is something that sits under the binoculars of the microscope for lasers that are bad for your eyes. So a CO2 laser, because you have just a physical barrier between you and the laser, the user doesn't need to have a pair of goggles in the microscope. There's no filter. But for this one, you do have to have one in the operating microscope. They normally just remain in there the whole time. The glass looks clear, but it does actually emit the wavelength. So the system just asks you if you've got that.
And if I'm using the scope, do I need the filter as well for the scope?
So in the scope, you can have a small disc that I have in here. So you still have to wear goggles if you're using an endoscope, but to reduce you do see a lot of flashing on the screen, and it can obscure your view of the surgery, because obviously you've got the scope here and you're looking at the screen. So you can get small endoscopic filters that just pop into the top of the endoscope like that, and then you put the camera in between. So again, that emits this type of light. And the same principle as the eye safety filter, you've basically got a binocular one of those that's a bit thicker that sits in the microscope.
That's why the autolays, if you use the fiber, you don't need.
You don't need. No,
you don't need anything.
You just need goggles.
Of course, yeah.
Or if you're using a microscope, no goggles. The general rules with the fiber diameters is 200 micron for the ear, 400 for the 0.4 millimeters for the nose, and 0.6 for the throat. Or you can use 0.6 or 0.4 for either nose or throat. And the other fibers come. I did have one open. Another one. Just a second. Sorry, they're in date. I might need to mix that through. Did I get it? Thank you. So the other fibres come as a bare fibre, where you have to use it separately with a handpiece. So a typical scenario would be if you use, say you were doing, so this laser can be used for like HHT, so like telangiectasias in the nose, because it will coagulate the red vessels. So you could use this sort of fibre with this smaller sort of nasal handpiece here. Thread that in there, and then we just want a small amount of that showing through. And then you can attach suction onto there as well. So whilst you're lasering, then it's actually removing the smoke. And I've got a couple of red and green apples over there, which quite nicely illustrate the absorption of the green. So the green.
Does that get locked in on,
Sorry, on this. So it's quite firm.
Okay.
What you can do with a smaller diameter is you can run a steri strip just across the top here to fix it. It's quite useful. Another thing you can do, Omar Muller does this over at Doncaster, is with the
I put it on the regular section even.
Sorry?
I put it usually on the regular section. Just you can stick it on the regular section or in instruments.
If you're using it with an endoscope, it can be quite tricky if you're trying to use them independently. So what you can do is try to pair your hand onto the endoscope and use the endoscope as a guide. Alternatively, what you can do is have this just slightly ahead of the endoscope, and you can just tape it. Just strip on.
That's what I was saying. I used to do this, even on it, on an instrument or section.
I hadn't actually. I know it sounds so simple, but I hadn't seen it before. I've been doing this for 12 years. And he just used it as one thing, just one guide, worked brilliantly. But other people like to have the sort of independence.
To be honest, as I said, you can put it on the grasper.
Yeah.
So you have the two mouths. The fixed one is of usually the fix, and the other one is to close. So put it on the closed one. So when you open it, you can see it.
Yeah.
And if you have a curved one as well, once you do like a little bit of a crunch, you will find it's going to the exact angle that you want, and you can rotate it up, down, anywhere in the length, which is amazing.
So like a classic sort of type of lesion is like a round anterior contour, where you can't get straight line view with a CO2 laser. You can't get that access. So how do you do that? Well, you probably need some sort of handpiece and fibre. CO2 laser is going to be the best wavelength for cutting. But sometimes for papilloma, you're actually trying to preserve the cord underneath, and they do have a vascular element to them. So this laser will target the what's feeding the papillomas, and it will also leave the...
That's what we said, the blue laser and the green laser. The colored laser is the best for targeting the blood vessels below the mucosa, and you've seen it on the video. It ablates the blood vessel without cutting the mucosa.
Yeah, because they're obviously and that's the whole principle of lasers, is that they're selective, and they're the only surgical tool that is selective in terms of identifying tissue and the necrosis. And so what you can do is you can put a fibre down there. You can bend this. It has a small stellette, so you retract the fibre, put the plastic stellette in, then you can bend this without it kinking, and then pop the fibre back in, and then you can create that bend to get access. But sometimes without a fibre-guided laser, if you have just a CO2, you have to abandon the case, and then the patient might be down a different pathway. Because you can't.
Down flexible scope as well.
So you can, so you can just thread the fibre itself on a flexible scope. You've got obviously some things that you have to sort of watch out for. I know Omar Miller over at Doncaster, he does it with flexible scope, and he does the local procedures under local, again on the course. So I've not seen much of it, but it is possible because you've got flexible there. So if we get some goggles, we can have a go and do some lasering. Have a flash or a repeat pulse. So the laser is on. Okay. Again, not much happening. 1 watt isn't. You can hear a little crackle there. Maybe if we turn it up to 2 watts, we'll get a bit more of an effect. So as you said earlier, with your with the maths, the formula, you have the energy, you have the duration, but you also have your distance and your speed of movement. Those are the factors with fibre-guided lasers. Very important, because 2 watts in close contact is not the same as 2 watts away from contact. And then if you want to increase the effect, we can go just to continuous. So 1 watt is the maximum, and this will just be on all the time. So it's basically like cooking. So it's the heat stacks, and you will just burn a hole. Okay? So we have single pulses, repeat pulses, and continuous. Again, this is the typical setting for cholesteatoma, where they're trying to paint the whole cavity to remove this or kill the cells that you can't see, and it's proven to reduce the recurrence rate. So they're actually trying to do damage, but because they keep moving from a nice distance, you can be very gentle like that, just with your speed of movement. Whereas if you stay in one place, the heat will stack, and then you see we begin to get some smoke. So it's always a balancing act between the settings, the fibre diameter, or the energy density, the proximity, and the speed. Okay? So with a single pulse, we're probably trying to be very, very precise. With an intermediate pulse, we're probably being less precise, but still scanning over an area. And with continuous, you're kind of doing a generalised...
The same, what you're saying is the surface area But the movement is that you're getting larger surface area, so it's directly proportional, so the energy will be less. So it's the same idea of the beam. But in the laser, you have an aiming beam and you adjust it because you focus by the microscope, but then the focal length is fixed. But here, your focal length is your hand.
Yeah, so that's focused and that's diffused, basically.
Yeah.
Another good analogy for the beam diameter is like a high heel. You know, you might weigh the same wearing some flat shoes, but if you put a high heel on, the pressure going through that high heel is much, much higher. And that's the same as sort of beam diameter. So if I put, say, 10 watts through a very small beam, the energy density is very high. But if I put 10 watts through a wider beam, the energy density is more, it's just more dispersed. Yeah. So that's
why my boring presentation was useful. Okay. I know that everyone says that we couldn't understand it, and then when they come in the theatre, they understand why I'm saying.
Yeah, and I mean I've been doing this a long time. So when I first started, I didn't understand the laser specific terms, everything. It was very confusing. But over time, I've done enough training sessions with not just at surgical level, but with the auxiliary physics, where you can see some of them, they don't understand what the difference is with the continuous and pulse. So I've tried to come up with analogies that make it a bit more
easier.
Yeah, every day. Yeah. So the torch, the high heel.
Yeah.
It's normally they
Out of curiosity.
Yeah, these have quite a few different ranges. Anyway, this one's very simple, but this laser does have actual here. So we can input parameters into that one, so you can have like staples, mastoid, and so on, but it doesn't have any that are inbuilt. This one does actually have inbuilt parameters for ear, nose, and throat. So if we were to go larynx, papilloma, it will bring up the suggested settings. So again, you've got the other factors, which are your distance and your speed, and you've also got the fibre size. But this will give you your basic parameters to start with, so a bit less setting up than that one. So if we can give this one a go. Hand pieces and everything are very similar, so anything that works, these are compatible with any laser fibre really, and we just want them sort of just showing tips. You've still got control. If they're a bit flimsier, so the smaller sizes, the more you have there, the sort of they can kind of lose a bit of their rigidity. So if you get it just there, you get a little bit more control. So let's switch for this one. Another sort of typical thing you see in theatres, sometimes because you might have multiple pedals underneath, what can happen is you accidentally flip the pedal round and you go to press it from here, and then you say the laser's not working and everyone panics. So if you ever see the laser's not working or say it's not firing, always just check that someone hasn't just rotated that. You see that quite a lot. So if we go laser on, and then again we've just got our red. So that's our red aiming beam. So this one has got slightly higher absorption in oxyhemoglobin, so in red, but 10 watts is quite high, so we'll put that down.
And as we said, this is the time. So we have the time for the pulse itself and the time for the relaxation. So between how much the time is between each pulse itself.
Leave 4, and then you can see something a bit punchier than the other one. So very short pulse duration, and because that pulse duration is so short, we're not getting much effect. If we go into a slightly redder bit, we might get.
This is a calculation.
Yeah,
we can just go for more.
Increase the duration.
Yes, that's it.
We're still very, very short.
Still,
We go to a different.
So,
Let's go to a different setting. Let's go. Let's go nose. Yeah, so
too
slightly
much.
longer.
Yeah.
So we press ready.
Okay.
What does that say?
So,
Okay,
version errors.
Try again.
Yep, it's on. Should be on. This is longer.
Yeah.
With the low watts, but we can increase the watts a little bit. So
Yeah. I think well, this machine will go up to 40 watts continuous.
Yeah, it's ready.
And 20 watts in pulsed mode. Yeah, so you can see that. You need to get a little bit there.
Yeah.
But yeah, it'll be interesting to see the difference between the blue and the green laser when we actually start getting this out doing some cases, because I have heard it's meant to cut better.
Yes.
One other factor that is important to consider with lasers is not just, when you saw the graph earlier about the peak absorption, you might have noticed that some of the lasers here don't actually have the peak absorption for the chromophore. Might be another wavelength. So there are a couple of reasons for that. One is the cost of the lasing medium. So how easy is it to manufacture a laser that can produce that light? Is it cost effective? So these are around the 35,000 mark. A proper surgical CO2 laser is over £100,000. So if you can't manufacture them cost effectively and reliably so that they are reliable systems, that's one factor. The other factor is sometimes the highest peak absorption isn't necessarily the most selective. So how close is the highest absorption to the other chromophores? So it might be, so this one is quite high in oxyhemoglobin, but it can also absorb some melanin. Now that can be useful. But you want a balance between the high absorption and the most selective. And the way to look at the selectivity is the distance on that graph between that chromophore and another one. So if they're very close, it means actually, yes, you might have high absorption, but it might also be targeting something else. So you want the selectivity and the absorption and the cost effectiveness, really. Because sometimes I looked at that graph and when I first looked at it, it's like, well, actually, that's not the peak. Yeah, because peak oxyhemoglobin is yellow light, 577, which is higher than that, less than this, but it's the selectivity is what you're after. So they do use yellow lasers in ophthalmology, so for like retinal bleeding. Obviously your eye, lots of delicate structures in there, so they need the highest absorption to limit any damage to the other structure. And they can actually laser on the fovea, which you can't do with a wavelength. So you can't use a green light laser on the fovea, but you can use a yellow light laser because the absorption is higher. But yeah. Does anyone want to have a go?
And then, so we say laser ready, and so once it's set up, it should give you 5 seconds, and then giving the beep, so 1, 2, 3, 4, 5, and then you'll find the laser is there.
It's a bit of heat, Robert.
Yeah, and so it doesn't matter. It's not really heated, so you can attack to just catch it from whatever the area that you want, and then so you make sure that the bezel is there, okay, and your leg will be in the large place to put in, and then once it's there, you can start it and say, I'm gonna pulse. Everyone keep clear, and you can see the nice cut effect. And it doesn't matter if you touch it or not, you will keep cutting. It doesn't matter. I can put the fiber, but it will be broken. So I say if you keep it like that, you can see the effect. Still, you can see the effect. And if you push the coagulation, which is up, you can see this one. So just push coagulation. Yeah, you find the coagulation is continuous and it's just almost 1 watt or less, and you can see the nice coagulation effect here as well. If you do this, okay, and you can see that if you touch it, you will broke the cover, but you can see that I'm just ablazing the small or depigmented the surface without having any effect on the main cover, so it's all works down. And just please stand by, laser stand by, please. Yeah, so laser stand by, and you can see the difference. You can take your goggles now, and you can see the cutting is really sharp in, and this is the coagulation effect, which is nicely there. And this is what you need to do. Just try to cut using the cutting or the coagulation. Just make sure you wear the right goggles, yeah. And also you can see here on the apple, so this is what I've done. So because in the meat is a little bit darker, but this is very nice. You can see the change of the pigmentation without losing the skin. So in the cutting you can see it's deep and cut, yeah. But for the coagulation, yeah, you can see it nicely there. Yeah, so more likely to be a change of color. Okay.
There is your correcting there. Yeah? But part of it is just not being nervous, because what's the worst thing that's going to happen is the sheep's not going to say bar again, isn't it? That's the worst thing that's going to happen, which doesn't really matter in the grand scheme of things.
It is tricky to coordinate your hands, you know, and find the joystick and you can't look at it. You know, everyone, it is difficult.
And we get that, but the thing is, the time to practice is now.
Yeah.
Because if you can't get it right here, nobody's going to let you practice on person. Like literally. So, you know, that's why I'm being predictive about getting you in the right position. So if you think about exactly what you've done here, so far, thank you very much, I'll switch places with you. You've got mobility here, here's your lesion down there, I'm not going to grow it too much. You've made some of your lateral cuts. You need to then basically, where is tube, bring it up here, and actually make those cuts. So you see there, superiorly, you've not made a horizontal cut.
Yes.
Yeah, down here, you partially made it. Not like you're scared of going medial. Like you're not going to get airway fire. Yeah. You're not going to get a voice dysfunction. So here, you need to make a horizontal cut.
No.
Here, you need to make a horizontal cut now with big fat fingers. You need to make those cuts. Once you do that, the entire thing will want to roll out. But remember, it's a 3D structure, like I've drawn on my arm. Your tumour's here, make your lateral cut here, then either choose your inferior cut or your superior cut. And I think for you, the winner there would be your inferior cut because you're half done. Then I'd do your superior, then I'd roll everything out, and then I'd worry about how you took it off.
Yes.
Does that make sense?
Yes.
Yeah, so it's kind of, in effect, we're doing a variance between type 2 and we're doing either type 2 or type 4 here, basically, that we're just judging it as you kind of go. But because they're the tricky ones, yeah, type 4s are relatively easy compared to type 2s because they're just ready.
Just warm me up. Later on.
I'm actually slightly out, and then it is not in focus. Now we're in focus. Oh, you're fine, don't worry about moving where it's fine. I'll manage with whatever. So, what I'm saying to you, you need to listen to this, is when you look at the screen. Yeah. And that moves up and down, that's it. Yeah. There you go. Natural cuts. That shows me how deep I've gone. I can see there very clearly the fibers are splitting here routine of section. So, thank you very much. So when you look at this, yeah, everything I said to you, I just did. Yeah. So I made a cut there. I found the depth.
Yes.
I made a cut there. I did that late. I did this one here. I found the depth of it, and then rolled it out, and then rolled it over, and then I chased it. So the important thing is not to be afraid, but your laser only gets moved with this, yeah? And it's little movements which allows you to do that. Then what I did, like I said, so that is the orientation of the specimen. So I applied traction across